same time. So Dr. Hisham is already on the week, and then Dr. Hassan is somewhere here. I think the second speaker. Yes. So Dr. Hisham. Correct. So right after Dr. Hisham, I actually call that lunch after lunch. Guys, okay, I can see.
Shall we start, everybody, please? Welcome to this afternoon session. It's very nice and cozy. I like the numbers, I like the room. And what a better start to the afternoon session than Dr. Hisham Rami, Professor Hisham Rami, who is a professor of psychiatry at Ain Shams University, Cairo, Egypt. Professor Hisham is a professor of psychiatry at the Institute of Psychiatry, Faculty of Medicine, Ain Shams University, Cairo, Egypt. He's also the Secretary General for the Egyptian Psychiatric Association and Vice President for the Egyptian Psychiatric Association for CBT. Professor Rami graduated with master's degree in neuropsychiatry from Ain Shams University in 1994. He then obtained a diploma in psychiatric practice, University of London, 1995. Subsequently, he completed a doctorate in psychiatry at Ain Shams University, where he has also undertaken his specialist registrar training for consultants in the UK in 2002. Professor Rami has authored over 30 peer-reviewed publications in well-respected national and international journals. He has received several nominations and both national and international awards in recognition of his work, including Fellowship Award for Best Research in Mood Disorders from France, the Aukasha Award for Best Research. He sits on the editorial board of Current Psychiatry, the official journal for the Institute of Psychiatry, and the list goes on. So without further ado, please put your hands together and welcome Professor Hisham. He's going to talk to us today about the everlasting challenge of stigma in psychiatry.
مساء الخير or good afternoon. Thank you very much for the nice presentation like this. I'm really grateful that you all attended because the coffee break is downstairs now working and they have lots of food and lots of coffee. So thank you for leaving all this and coming here today. My presentation today is going to be regarding the stigma in mental health, of course, how it is the everlasting challenge in psychiatry. This is my name and the post I hold right now. I have been elected as the Treasurer and Associate Secretary of the Arab Federation of Psychiatrists quite recently, and also elected as the Chief Editor of the Arab Journal of Psychiatry, just to add to what you have said. This is the picture of the first director of the World Health Organization. To my amazement, he was a psychiatrist. So the first director of the World Health Organization, منظمة الصحة العالمية, was a Canadian psychiatrist. And it was in the year 1948 when the WHO was first established. And he was the one who decided that the motto for WHO should be like this: there is no health without mental health. Since that time, 1953, now we are 2023. Unfortunately, this has not been done. Up till now, mental health is not a priority in the WHO. If you know the structure of the WHO, they have many departments. One of the departments is the Department of NCDs, non-communicable disorders. Mental health or psychiatry should be under this umbrella, but regrettably, they do not do this. Mental health is an affiliate department that has no relation to other main specialties in medicine or even NCDs, despite the fact that this person has advocated that mental health should be the integral part of practicing medicine in general. So why is it important that we should and continue to fight the stigma of mental illness? I will imagine a hypothetical situation where we are able to have what is known as universal mental health coverage. For some reason that I hope will happen, the governments decided that everyone on the land of Abu Dhabi or in Cairo, Egypt, would have the best mental health services. So this box will be covered completely. Everybody is covered, all services are available and for free. Would people go to seek those services? Would people go to seek help? I'm arguing that they will not. You will have the services, you will have the resources, and you have the policies, but people will not use the services because people are afraid to admit to themselves and to the community and to their families that they are suffering from a mental illness. In one study we did in Ain Shams, how do medical students consider psychiatry or patients with psychiatric disorders? Weak persons, people that are away from God, or they are bad people. Even people who have studied medicine, this is their attitude towards mental illness. Let's imagine how the public will behave if we have this. So even if we convince the governments to spend all the money and have the resources, I'm arguing that we will not achieve universal mental health coverage unless the stigma is removed. Of course, the stigma prevents the government from spending money already, but I'm imagining. What is stigma? What do we mean by stigma? I'm not going to bore you with many definitions. Very simply, it's a knowledge problem. It's an attitude problem, and it's a behavioral problem. People are not, the word ignorant is very strong, but people do not know a lot about mental illness and how it is related to the brain. People think that it is a behavioral problem related to bad parenting, people who are not good people, and so they are behaving abnormally. So we need to change the knowledge. Consequently, due to the lack of knowledge, they have a negative attitude towards people with mental illness. And I will show you even towards people who work in mental health and regarding services provided in mental health. And consequently, they behave accordingly. So the people with mental illness are discriminated. Let's imagine a hypothetical situation. This nice guy has a nice daughter, and a nice man comes to marry her. I have a history of being admitted to a mental hospital. Would he agree that his daughter would marry this person? I did the same question in a workshop that included psychiatrists, and 90% of them said no. Even people working in psychiatry have a negative attitude towards people with mental illness. So it's a problem of knowledge, problem of attitude, and problem of behavior. So why is it important to tackle this stigma? Because it impacts a lot of things. It is the most important barrier to seeking help in the community. It reduces of the likelihood of people contacting the service for help for being afraid of being labeled or discriminated against. Reduce the willingness of policymakers or decision makers to invest money in mental health services. And this is why it is, like Professor Afzal was giving us in the plenary lecture, if you are going to consider psychiatry to be a public health problem, we should remove the stigma of psychiatry. It limits access to even employment. Let's imagine you have a new company and people are coming to apply for the job, and one of them in their CV or during the interview said, I have been treated for OCD or I've been treated for depression. Would you hire him or not? Or would you hire her or not? So it limits access even to employment. It reduces what is known in the concept of self-stigma. Even the patient herself or himself look really low regarding his abilities, his opportunities in life, and it contributes to the abuse of human rights. People with mental illness should be treated equally like any other individual with dignity, and they have rights. When they are labeled as mentally ill, they should not write their own will. I don't trust them with decision making. So it has many impacts on the life of patients. I'm giving you an example of one of the patients I have seen when I was in training. That was back in 1996. He said, I suffered from a bad mental breakdown when he was hospitalized 5 years ago. It was very traumatic. There I was, the eldest son, suffering from severe depression, crying, unable to work, often threatened by my own dad as being weak. So this young man was severely depressed with melancholic features, suicidal features. He was admitted to a hospital for 3 weeks. His main problem was his father was labeling him, you are a weak son. This is another patient. His name was Basim. When I got sick for the first time, I was 17. At that time, he was at high school. My behavior was awkward, and my friends and classmates were making fun of me. Very common in Egyptian schools. I'm not really familiar with what happens in Abu Dhabi schools, but this is what happened. People are bullied when they have acting weirdly. Then I was hospitalized. When they found out about this, all my friends stopped bullying me. They stopped actually interacting with me at all. I lost all my friends. This is how bad stigma is. Let's imagine the same person, Bassem, طبعا it's wrong, this is not his legal name, was suffering from a broken leg and admitted to hospital and had an operation and returned back to school after a few weeks. Would people have abandoned him like this? But because the term mental illness or the term depression was mentioned, Bassem lost all his friends. This is an awful poem by one of the mentally ill patients. They don't call me sad. You know the famous quote, sad, bad, or mad, right? He was telling us, they stopped calling me sad. They don't call me bad. They don't call me mad. The problem is they don't call me at all. Can you imagine the suffering of this individual? He has a mental illness, probably causing him severe internal pain, and then suddenly everybody abandons them. Does this requires us to act immediately and forcibly to remove the stigma or not? I'll just tell you the impact of stigma throughout the history of psychiatry. I'm not sure if anybody is familiar with this man. Nobody. But we all should be familiar with this man. This is, do you remember him? Darwin, huh? And his famous theory of evolution and the baqa' al-aslah and all this. This is the cousin of Darwin. Huh? His name was Francis Galton. And according to his belief in the theory of evolution and good genes and bad genes, he tried to form a society in London, UK at that time, to advocate for genetic hygiene, which was a public health perspective. Let's prevent mental illness by getting rid of bad genes. Fortunately, in London at that time, there were many liberal philosophers and liberal decision makers, and they refused his concept. So where did he go? He migrated to Germany. And down there, based on scientific knowledge regarding that many of our mental disorders are genetic in origin, many of people believed in him, and they formed something called the German Society of Racial Hygiene. One of the, sincere students of this society was this famous man, Adolf Hitler. So in order to get rid of bad genes and save human beings from all bad genes, let's get rid of those. In their thinking, Jewish people, Gypsies, even Arabs, but they didn't have the chance to finish us, and black people or people of African origin, and people with mental illness. So resulting from the stigma that mental illness are due to bad genes and not disordered genes, people with mental illness at that time were put to burn. Huh? Luckily, this did not continue for a long time. In the year 1911, a very famous man that I'm sure you are all familiar with, the man with the big cigar, drinking whiskey during breakfast, the man who saved the world from Nazis, the man who saved democracy in the Western world, Winston Churchill, a very enlightened man, a man who reads a lot and has many liberal thoughts. What was his view of mental illness? This is from his speech in Parliament. In 1910, summed up his attitude and the attitude of many contemporary philosophers and decision makers. The feeble-minded and the insane classes constituted a danger which is impossible to exaggerate. The source from which the stream of madness is fed should be cut off and sealed before another year has passed. Luckily, he decided not to burn them, but let's sterilize all people with mental illness. I'm trying to emphasize the point that stigma might lead to disasters like this. How the media contributed to stigma in Egypt. How many Egyptians are here? Or how many people who watch Egyptian movies? Huh? How mental illness is pictured in Egyptian media and movies. Huh? This is one of the most famous comic or comedians in the history of Egypt. This is one of the most important films in the history of black and white movies. It's called إسماعيل ياسين في مستشفى المجانين. إسماعيل ياسين in the lunacy or lunatic hospital or lunacy bin. In that, this was the picture of the patient in the hospital. This was supposedly to be Abbasiyya Mental Health Hospital, and he was admitted there wrongly. This is the patient. أصلاً عندي شعرة ساعة تروح وساعة تيجي. This is how mental illness is depicted. People are to laugh about them, not to be compassionate with them. They are a source of our jokes. Another interesting, which is not in Egypt, but this is how people with psychosis were depicted in the movies, giving the public the impression that you are either a silly person or you are a very dangerous person. Have you all seen this movie or not? An Oscar-winning performance by Jack Nicholson that earned him an Oscar prize at that time, his first Oscar prize, depicting a man who is psychotic, who was deluded and hallucinating, so he decided to kill all his family. This is how patients with mental illness are presented to the public. Not only this, are you all familiar with this? Nobody's going to be familiar with this. This is a very famous actress in Egypt. She was called the Marilyn Monroe of the East. I used to really adore her. Her name was Hind Rostom. So I went to the movie to watch Hind Rostom. Regrettably, the movie was not about Hind Rostom. The movie about Yusuf Shaheen at that time. This is Yusuf Shaheen, a very famous director in Egypt. Also, they depicted the patient, the psychotic patient, as a very dangerous individual because he had a delusion of love, of erotomania or the Clerambault syndrome towards her. She either marries him or he's going to what? Kill her. And this was the famous advertisement of the movie. So what about psychiatrists or mental health workers? How they are presented to the public? This is the psychiatrist. And this is the psychiatrist doing role play and group therapy with the patients. I don't know if you watched this movie or not. The psychiatrist works like this. أنا مش طويل وأوزع أنا إيه. So psychotherapy is depicted like this. You tell your patients, just remove the wrong idea and repeat the right idea several times, using a pendulum like this. Or be like the patients and try to change their minds like this. How about our psychiatric treatments? How they are presented to the public? Jack Nicholson, again, doing us a great favor for psychiatry. Another Oscar-winning performance, 1973, Flying Over the Cuckoo Nest. طائر فوق عش المجانين. This is how ECT was presented. If you are a patient and you watch this movie, and I told you, you need ECT, it will improve you really quickly, and you will be fine over a short period of time. Would you use it? Never. In other movies that I'm going to present, ECT was used as a torture mechanism. And you try to convince people that ECT can never be used as a torture mechanism because patients actually lose their conscience and they do not feel the pain. But still, up till now, in a university setting, tertiary specialized hospital, when you tell somebody you are going to use ECT for the treatment, what did I do wrong? Why do you want to hurt me? So the concept still persists up till now, preventing many people of using a very successful treatment method. What about mental health hospitals? How they are presented to the public? Are they presented as a general hospital, as a nice hospital where they are going to be treated and then discharged? No. They are presented as prisons. عندنا كده يعني saying in Egypt, الداخل مفقود. People who enter are lost. والخارج مولود. And if you luckily, for some reason, you are discharged, consider yourself reborn again. If this is the concept about the hospital, would people go to hospitals or not? Just a concept to think about. Why stigma is very important. Luckily, there are few exceptions where mental illness was presented as something that can be treated. I'm sure this is a new movie that many of us have watched. Anybody did not watch this movie? Beautiful Mind. One of the best scenes in the movie is at the end of the movie, where this guy, a very famous professor Nash who had a Nobel Prize in economics, suffered from psychotic breakdown so many times during the movie. At the end of the movie, he's back teaching in the university. And he told one of the students, she was coming out like this, asking a question. He got another student. Is she a real student talking to me or not? He told you, yeah, she is. So he started the conversation. So he became aware that there are hallucinations and there are real persons. And he told her, now, I'm not 100% cured, but the new medicines and the new treatments have enabled me to go back to work and distinguish between what is real and what is not real. This is a very good message to the public regarding, finally, that people with severe mental illness can be treated and they can go back to work, and that our new treatments actually help them achieve this. One movie. This is a neutral movie, but it's a very good movie if you want to watch it. Jack Nicholson, for the third time, this time suffering from OCD, presenting OCD as a funny disease. However, the message was, if you love somebody, you will be treated from OCD. Is it a good message or a bad message? It's left for you for discussion. So what can be done if stigma is so devastating like this? And there are many sources doing this. How can we fight stigma? What can we do to battle this so that we can provide better psychiatric services? This is a paper I was lucky to share with Professor Afjar Javed and many eminent psychiatrists. Was published in the year 2022, if I remember correctly, regarding a strategy to fight stigma in low and middle income countries. I'm not going to go through the details, of course, but you can read it. It was published in the Asian Journal of Psychiatry. But this is what we need to do. Change our health system. If we still deliver psychiatry in mental health institutions like this, and we are away from other branches of medicine, asylums, large hospitals, where people are away from others. Where are you going? I'm going to the Amal Hospital. I'm going to Abbasiyya Hospital. Why aren't you going to your GP? Why aren't you going to the General Hospital? This will keep the stigma going on. What about this? Why not consider psychiatry another specialty in medicine that is delivered by the GP, then by secondary care later on? And why not have departments of psychiatry in general hospitals? It's like having a heart disorder, it's like having a chest disorder, it's like having any other disorder. Why not do this? Very simple. And actually, economic studies have proven that this model is much cheaper than this model. But for some unknown reason to me, it's still, this is the prevalent model, at least in Egypt and many Middle Eastern countries. I'm arguing that using the techniques of CBT in public would actually help us change the attitude, the knowledge, and the behavior of the public. We can use the techniques of Albert Ellis, or we can use the techniques of Aaron Beck. Quickly, you all know this guy, right? Albert Ellis. He's actually the founder of the concept that knowledge, thoughts, are the reason for many problems in the history of mankind. So we can do this. These are the techniques he uses, and they can help us if we do what is known as campaigns, media campaigns, challenging the thoughts, the irrational thoughts regarding mental illness, providing rational thinking and good knowledge, and changing the people behavior, including policymakers and decision makers. Or طبعا both of them are dead now, فربنا يرحمهم هما الاثنين يعني. Or we can use this to achieve a change in the attitude and behavior of everybody towards mental illness. Catch the stigma, check the reality of your behavior, prejudice, and attitudes, and how it impacts the life of those people, change them to more rational behavior and attitudes. A very interesting quote: people who battle mental illness are not weak, they are not bad, they are not sad. But the third word is true. They are in a battle with an illness. Mental health problem is an illness like any other illness. And people, like they battle cancer and they battle diabetes, are actually battling their mental illness. Others who battle illness are respected. So why the stigma of mental illness? And thank you very much.
Thank you very much, Professor Hisham. It was a wonderful, comprehensive talk about a very, very important subject of which I'm sure people will have many, many questions and comments. But I would ask you to please keep note of that. We will have a panel discussion after the next session. So our next speaker is Professor Ahsan Nazir. He is a division chief for child and adolescent psychiatry, associate professor for clinical psychiatry, Sadra Medicine, Qatar. Dr. Nazir is a board certified in child and adolescent psychiatry. He has published more than 50 peer reviews, articles, books, and book chapters. He co-edited Behavioral Pediatrics, which is now in its 5th edition, in the clinical aspect of psychopharmacology in child psychiatry. Now it's in its 2nd edition and an associate editor of the Journal of Child Health and Human Development. He has written extensively on autism and autistic spectrum disorder, internet addiction, substance use disorder, ADHD, schizophrenia, childhood anxiety disorders. His articles appeared in numerous journals, including Pediatric Clinics of North America, the American Journal of Psychiatry, Biological Psychiatry, JAMA, Adolescence Medicine, and others. He is currently the co-principal investigator of a SURF, which is a grant examining the neurogenomics model in child and adolescent ADHD. Today, he will talk to us about current thinking and innovations in the field of ADHD. Thank you.
Thank you so much, Dr. Hashim. It's for a very kind introduction. Dr. Tamir. And Dr. Hashim, thank you so much for a wonderful presentation. It's amazing. And for the last about 6-7 years, I've been working in Qatar after spending most of the time in Michigan. And stigma in the mental health is a huge, huge issue that we are dealing with. My presentation is a little bit different. So we are just going to talk about some of the etiology, pathogenesis, some of the nosology, and also some of the new treatments that we are seeing in ADHD. Before I move forward, can I have a show of hands, please? Like, how many of you are treating children with ADHD? 4, 5, 6, 7. Okay, that's good. So, I'm a child psychiatrist by profession, 100% child psychiatrist, so most of my presentation is about that. But probably I think a time will come when you'll be able to use some of these concepts in the adult population. So I don't have any conflict of interest. And just briefly talking about the adult ADHD. Adult ADHD is a really interesting concept as a construct. Quite a lot of child psychiatrists in the beginning had a strong difficulty in figuring out how we are going to understand the child psychiatry, the adult ADHD, because we believed, I think in about 2010, 2015, that most of the people who are presenting as inattention and hyperactivity and impulsivity, they're basically drug seekers. However, as the time is passing by and more research is coming up from the longitudinal studies, what we know is that ADHD persists from the childhood to adolescence. And in about, I think, 2016, 2017, they were thinking that about 20 to 30% of the children, they move from adolescent years and they do not outgrow their ADHD. And when you see them at 21 years of age, 25 years of age, they still have the ADHD. However, the most convincing evidence that this is a lifelong disorder came from the MTA study. MTA is a multimodal treatment of adolescent study. It started in 1994 in the US, and I think it went till about 2013. So it basically covered the whole span of the DSM-4. And what they did is that they followed a whole cohort of the child and adolescent population over the course of 15, 20 years, and they just keep on evaluating them, and they had a humongous amount of data. So the most recent article that published in 2021, they say that if the child has ADHD, there is only 10% chances that they are going to have, that they're going to outgrow ADHD. So it basically means that 90% of these kids will continue to have some level of dysfunction when they grow older, and you can treat them as an ADHD patient. Now, if you look at the trajectory of the symptoms, you'll see that by the time the children are in adolescence or in the college year, the impulsivity and hyperactivity that are two biggest hallmarks of childhood ADHD, they go down pretty significantly. And in the college years and in the adulthood, inattention is a problem, and the comorbidities started coming up. So basically, if you see a person, let's say 25-year-old in your clinic, and you do a cross-sectional evaluation, you are not going to see the hallmark of impulsivity and hyperactivity. What you're going to see is a very vague symptoms of someone who is not doing well occupationally, someone who has a poor self-esteem, someone who has a relationship problems, someone who is in substance abuse, who is going through a lot of injuries and accidents, or you will see the initial presentation as the comorbid problems. You will not even know what's going on, as that there is an underlying subcurrents of ADHD. So quite a lot of, let's say, women, they will present with anxiety and depression, and in the men, the substance use disorder, substance use disorder over here and the personality disorders, they will be much more prevalent. So it's going to be really difficult to evaluate a person, 25-year-old, 30-year-old, in a cross-section and trying to figure out, am I looking at the ADHD patient or not? Because the symptomatology will be very different. They will not be fulfilling the DSM-5 criteria of the ADHD, and you will see a lot of comorbidities. However, whatever way you see the people, the way you see the adult population, there are only three possibilities that the patient will have an ADHD. Okay, the first one is a chronic course. Someone who came to your clinic, let's say at 5 years of age, they were diagnosed with ADHD, and you started following them up, and they never outgrow that. That's what the like a multimodal treatment of adolescent studies say. They say that 90% of them, they continue to have some level of dysfunction. This is going to be an easy group to follow and to understand that the child has an ADHD, adult has an ADHD. You're going to keep on following that. The other one is the group 3. Now, group 2 is the one that we love the most. Okay, they are the one that we treat them by 14, 15 years of age, they outgrow, and they have a really good prognosis in the later part of the years. Group 3 is the one that these are the children who have some struggles here and there, but they never really meet the criteria of DSM-4, DSM-5. But when you lower the threshold of the diagnosis at about 18 or 19 years of age, they started meeting the criteria for the ADHD, and you can definitely treat them over here. Over here, it's really difficult. Over here, you need to make a lot of case from the medical legal point of view also that the child is struggling with because they are not meeting with the DSM criteria. The most important one, however, are the ones who do not have any ADHD symptoms when they were in the childhood, but had an unfortunate incident of a TBI, of a traumatic brain injury, and it can be like a mild, moderate, or severe, and then had an uptick in about 10 to 15% of the cases with the symptoms that appear to be ADHD. They can be ADHD, or you can use the other classification like personality change secondary to a medical condition, or you can use it as like the patient who is presenting with a lot of irritability, anger issues, behavioral issues. It's going to be a really different, difficult differential diagnosis at that point in time if you see the patient. But the point of this slide is that there are only 3 type of patients you will see: chronic course that never improved, the patient who had subthreshold symptoms, and the patient who present with a traumatic brain injury. There is some literature about about the ADHD symptoms appearing first time in the adulthood. So far, so if you look at the literature, there are some people who say like this is possible. So from in the child psychiatry field, we don't believe that. So from our point of view, you need to be careful about this part, that if someone comes to you at 18, 19, 20, no previous history, no residual symptoms, no TBI, and they say, I cannot focus, I cannot pay attention, I'm very disorganized, there may be some underlying other issues going on that you really need to take care of in the differential diagnosis. And this is basically the data from the Taiwan in which they looked at about 70,000 patients. And they say that the people who have ADHD, they have a significant increased prevalence of the traumatic brain injury. So it's kind of like it cuts the both way. Now, looking to the etiology and pathogenesis, most of the kids who present with ADHD, all the people who are working with ADHD, you must have noticed that most of them present with comorbid disorders. It is very, very rare to find a very clean kid who have only clean ADHD. Most of them have either behavioral problems, conduct problems, ODD, anxiety, depression, autism, Tourette's. Altogether, about 64% of the cohort with ADHD have one or two mental health disorder. So what does it mean? It means that the ADHD is basically a prefrontal problem if you look at the executive controls and everything. But all the anxiety and depression and Tourette's and autism, they affect the other parts of the brain. So how come there is such a global dysfunction that is causing the kids to have 64% of the comorbidity? So researchers in the last decade, they were trying to figure out, or they had been focusing more at the time of the brain when there are some global changes happen, okay? So when the child is growing up, what's the time of the brain when a global change happen naturally, like from the Allah's point of view? That's the pruning, okay? Are you familiar with the concepts of pruning? So what happens is that when we grow older, when we grow, our brain also grow. And the way the brain grow is that it makes a lot of connections. This is a childhood brain. This is the 5 or 6 year old brain. Now, when the brain grow a lot of connections, of course, our ability to do things, our working memory increase, our planning skills increase, but also from the nature point of view, it makes it difficult for a brain to communicate because there are too many roads who are going to a single point. Okay. And what the brain do is at about 4, 5, 6 years of age, till about 12 years of age, it started cutting the synapses that are not needed. And that basically is called pruning. And the concept is that something happened during that shaping of the brain process when the brain volume is going down, that the children started developing these mental health problems. And there is a most recent study that came who supported this idea. It was in Nature Medicine in 2023, in which they looked at about 1,800 adolescents and did the imaging when they were doing some cognitive task. And then they looked at how different parts of the brain were interacting with each other. They found a pattern in the frontal lobes that they called a NP factor. So NP factor is kind of, think about as like if we have a high cholesterol, we look at the cholesterol, they say like, okay, the HDL is high, LDL is high. That's what they were trying to figure out. It has a prognostic indicator. But what they found is that NP factor is something, neuropsychopathological factor, is something in which there is a particular way the kids who have a mental health problem, their brain interact with each other. They replicated this study from the ABCD study. ABCD study is a NIMH study started in 2015, in which they are looking at a global development about thousands of adolescents and then trying to create a database how our brain grow. But when they compared the results with the genetic, they found that the patients in which they were having more NP factor, there is a strong association with IGSF11. And this is the gene that the variant of which can cause problems in the pruning. So the researchers say that when the pruning process is disrupted, it affects how brain regions talk to each other. So this is a very early studies in which we are getting more and more evidence that there may be something wrong with the pruning process. I can go to some interesting things if you're getting bored, because this is a really very strongly academic type of thing. But bear with me for 2 or more slides, and then we will go to something fun. Okay. Now, the other thing that the people are looking at is basically, are there any other things that can cause ADHD? And there are thousands of things. And a few of the things that you must have known about is the ACEs. Is it something that I'm seeing, like some people were saying yes. So these are adverse childhood experiences. So adverse childhood experiences basically are the childhood adversity. It's very simple, like the environment that you're growing in. And people consider them as traumatic occurrences. We'll talk about some of the experiences. If they happen before age of 18, they increase the toxic level of stress that impair the neurodevelopment and can cause a lot of mental health issues. And the first study that came out was 20 years ago from Kaiser Permanente in California. And after that, there was a string of studies, but it never really got the traction till about 4 or 5 years ago, when people started looking at this much more deeply. And this is a study in which they compared children with ADHD with the children who do not have ADHD, and found that the children who have ADHD, they have more prevalence of childhood adversity. And the prevalence was that their parents either were going through a divorce, there was a familial substance abuse, there were familial mental illnesses, or some of the parents were incarcerated. Okay? And again, just remember that we are not looking at the positive or tolerable stress. We're looking at the toxic stress, the prolonged activation of body's stress mechanism to some of the stimuli. And what happens when our body is stressed? Most of the time, our HPA axis gets deranged. It leads to anxiety. Our emotional processing goes downhill, and our brain connectivity leads to difficulty understanding in the relevance of the stimuli. Okay. And this is an interesting study. This is a comparison basically of the original ACE study about 20 years ago and the expanded ACE study. And in the original ACE study, they found out that only 21% of the people had 4 or plus ACEs, and I will tell you why it is important. And now this study, I think it was in 2020, 2022, 37.3% of the children had more ACEs. So basically what it tells is that children are growing more and more in a childhood adversity, that they are having more and more problems at the time of the upbringing. And what the ACEs do, it lead all of us, depending upon which childhood we bring in, to a lot of behavioral and physical and mental health issues, increased chances of heart disease, suicide attempts, diabetes, cancer, stroke. So ACEs are basically rated on a scale of 0 to 10. So if you have an ACE of 4 or more, it increases your risk of emphysema or chronic bronchitis by about 400% and suicide by 1,200%. So what I would like you to do, that sometime when you're free in the later part of the day, go to Google it and say like a ACEs calculator, and it will give you a web page. And you can, it's like about 15 questions, I think, and you put the answers depending upon what your childhood have been, and it will tell you what your ACE is. Okay, so if your ACE is a 4 and below, it's all good. If your ACE is a 4 and above, you guys are going to be in a little bit of a pickle. So you need to figure out like how to change your lifestyle, how to improve by taking less stress and all that stuff. So this is really interesting to do if you guys want to do it. Okay, now a little bit of a fun stuff. So nothing really changed in the last about 1 or 2 decades as far as the medications are regarding the ADHD. The only thing that changed basically is the way we deliver those medications. And we still have the same stimulant medications, we still have the same non-stimulant medications, and most of those medications, they are targeted to take care of the time when the child is in school or the people are at work. But in the child psychiatry, there is one time of the day that is the most stressful time. Any guess what time of the day is that when you're working with the children? As a parent, you can say, what's the most stressful time in a day? Exactly, going to school. Because if there are 2 or 3 kids over here and they're all going to schools and getting ready and mom and dad are going to the work, it's going to make things crazy if you have an ADHD kid who is just running around and who is not taking care of themselves. And there are studies about that. This is a survey from parents, and with the children, 74% they say are easily distracted, they do not listen, they are unable to sustain attention, difficulty organizing tasks. It gets really difficult to the point that 80 or more people, the patients say that the parents say they feel overwhelmed. They say that I raise my voice, I feel constantly stressed, I feel inadequate as a parent. And if you reflect it on us as a parent, sometimes we are in a happy mood, sometimes we are not. Sometimes when we yell at kids, after 1 hour, we feel so bad. So think about us as a parent living with someone, a child, who is consistently challenging us in the morning, and we consistently finding ourselves yelling and screaming at them that move, 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 we need to go to school, we need to go to work. So just to target that, a recent, like in, I think in not 2018 actually, a medication came, it's called Genre. It's a methylphenidate preparation in which the child take it at the bedtime. Okay, so these medications, they are not available, I can imagine, over here or in Qatar also where I practice, but it's just a good idea to just understand that where the field is going. So the Genre PM, the child take it as about 8 or 9 p.m. It goes through the system, it stays in the colon, and then it starts getting absorbed by the time when the child wake up, about 4 or 5 a.m. You will start the methylphenidate peak going up, and then it works as exactly any other methylphenidate preparation. And the results from the random RCTs, they found that there is a marked decrease in the parent stress, that the child, when they wake up, is a little bit more in control of his behaviors, listen better, do well. The other medication is viloxazine. Viloxazine is the kind of like brother or sister of Strattera. Have you used Strattera? Yeah, Strattera is a very common medication. And in 2021, it was approved by the FDA for the patients 6 to 17 years of age. It is an SNRI. So if it is an SNRI, basically all the antidepressant black box warnings they apply on us, and that is increased suicidality. It affects the serotonin, it affects the norepinephrine and dopamine. And there are no head-to-head studies so far between viloxazine and the Strattera. But in the placebo, with a 100 milligram dose, they saw a difference in the symptom improvement as early as 1 week. Surprisingly, they did not see this difference at 400 milligrams at 1 week, but at least 100 milligrams they see that. In the clinical situations, what they found is that Strattera takes about 3 to 4 weeks to work. Viloxazine takes about maybe like a 1 week to work. So that's the only difference. Suicidal ideations and everything is still the same. Okay. Stimulants and cardiovascular safety. This is another data from, I'm going to rush through some of the slides over here. So this is again from the data from the MTA study in which they followed the kids for 10 years. They checked their blood pressure, pulse, and all that type of stuff. And they say that the stimulants, like a methylphenidates or Adderall, they do not make a lot of changes in the cardiovascular, other than if you look over here at 14 months of age, there is a significant difference between the resting heart rate in the people. And resting heart rate in an adult population, increased resting heart rate has a very strong association with mortality. Okay, so that's basically one of the things that you need to take away from this slide. Then there are some devices that are FDA approved, and one of them is trigeminal nerve stimulation, a nerve stimulator, and the other one is a video game that is approved by the FDA for the treatment. So what the TNS do is that it activates the nucleus tractus solitarius, and it activates the orbitofrontal cortex, especially the right and the medial. And this, why they start thinking about the TNS, what they found is that TNS is something that's used in depression. Okay, some of you probably may have used that also. So after the treatment of depression, when the patients were filling the forms, they were also noticing that some of the attention and concentration has also improved. And they say, well, you know, we are seeing this a pattern consistently, why we cannot use it in the children population. And they also do the PET study, and they also see that some of the areas that are associated with the ADHD, the TNS stimulate those areas. So that's another area, that's another thought came up. Okay, well, we can start using it in the children. So then it was approved by the FDA for 7 to 12-year-old kids. It is a patch that sit on the forehead, and it stimulates the brain for about 8 hours every night. And the most common side effects were fatigue, headache, and increased appetite. So this is how this is one of the picture from one of their commercials. The patch is over here. She's connecting the wires. Press the button, and for the next 8 hours there is a stimulation. This is the ETNS data, and this is the sham data. Sham data basically means like a no stimulation, and they saw improvement in about first 1 week. Overall, the improvement is the same as you see with a non-stimulant like a Statera and with atomoxetine and everything. So the other treatment is a video game. So that is approved in 2020 by the FDA. The concept is that the software send motor and sensory signals to the brain. It automatically adopts the kind of like the strength of the game, and children hopefully learn something and then improve. So this is what the video game looks like.
And unlock new characters. Are you ready to start exploring? Awesome. Introducing Endeavor RX.
So as you can imagine, kids are loving it because it's kind of like it's a prescription based. You go to the doctor's office, they kind of like they have this 20-minute session, 25-minute session. Parents pay for the money, and then I think it's about $100 per session, and then they see then they move on. There are a lot of studies. This is the most convincing study in which they followed about 350 patients who are 8 to 12 years of age, and they followed them over the course of 1 month, and they noticed some improvement. So the improvement that they noticed when you look at the study, one of the things that you need to look at is what's the primary outcome. The primary outcome was an improvement in TOVA. Okay, so TOVA is something that you put the headphone on, you sit on the computer, you kind of like you either inhibit your responses or you give the responses. So in the laboratory, when they were doing this study, they noticed that scores of TOVA improved, but when they asked the parents and the teachers to fill the ADHD rating scales, none of them saw any improvement at all. So there is a concept in the child psychiatry, it's called near transfer to far transfer. And near transfer basically is that I can teach you something over here, but when you go in the real world, you may not be able to use that. That's what the problem with these devices. So they are trying to use a virtual reality in a real life experiences type of thing. This is, for example, one example.
And I started thinking, well, why can't we do that with virtual reality? So what we've created is a virtual classroom. So they're sitting in a classroom and they look around, and there's children behind them, and there's children in front of them. And every once in a while they're doing their math test or these other attention kinds of tasks, there's a child leaning over talking to another one, which is very distracting. You know, the child might drop their pencil. Typical distractions one might encounter in the classroom. So the idea is that while they're doing their work, they can also be exposed to these distractions and learn to ignore them.
I probably got a few answers wrong because of it, but not that many.
So at this point, what the therapy entails is that they've done a practice session here, and we're using eye tracking so we can gauge whether or not they're distracted. Then they take home with them, they take a virtual reality headset and a cell phone that we give them, and they're instructed to practice about 20 minutes a day for about 25 sessions. Ultimately, we want to assess whether this changes their behavior in the classroom or at home. So we're also taking rating scale measures because that's the beauty of virtual reality, is that it should transfer to real settings. And so we want to assess whether there actually is a change in the real setting.
So that's the concept, whether they can transfer the real setting. And so far, there have not been any convincing studies because these things are based on a type of therapy that's called CT therapy, cognitive therapy, not the cognitive behavior therapy. Behavior therapy works, but the CD, cognitive therapy, and it has been over there for about 40 years, and so far FDA has not approved that. How far this will go, we don't know. It may be the kind of like the as an addition to whatever the other treatments do. But anyway, thank you so much. I think that I saw Dr. Tomer looking at the watch, so it looks like I'm running a little bit late. But I appreciate you bearing with me and listening to this.
Thank you, Professor Nazir. Very, very wonderful and rich presentation. Now we have the floor open for questions. Please, for the two presentations, Professors Rami and Nazir. Of course. Yeah.
We'll change the setting. I will ask the question. What's your experience?
Sorry, doctor. First of all, thank you so much for excellent two presentations. But I have two concerns, both related to both lectures. You talked about stigma, and you gave us one of the solutions, opening up centers in general hospitals for psychiatric centers, for psychiatric wards, okay? The issue is back in Lebanon in 2005 when WHO decided for the mental health gap to make each general hospital have a ward. Most of the hospitals did open up a ward, psychiatry, but the stigma is still there. So honestly, I'm here because I'm willing to understand how can we break the stigma, because it's still there, one. And two, psychoeducation. Anna, I believe in psychoeducation from day one, that the baby, schools, community, and early detection, and therefore prevention or early treatment to avoid any sequel in the patient's functional. And just a quick observation about the child that you just showed, Dr. Nazir. When he talked about his ADHD, he said it with he was so affected, and I didn't make so many mistakes. So the stigma is still there. We can see it in the child's body language, So what are we doing? How can we finally break up this thing? Thank you so much.
If there was a simple solution for the problem of stigma, we would not have been sitting here together now discussing stigma. What the proposal is, which type of service delivery is less stigmatizing? It is not the solution for the problem of stigma. But the question was, we have many models of delivering services for people with mental illness. Which model would be less stigmatizing? It is not a solution for the problem of stigma. It was my idea to advocate the concept that mental illness is like any other illness. It should be managed in the same way exactly. If you are managing hypertension, first the patient who suspects that they have hypertension would go to the GP, then people who suspect that they have mental illness should go to the GP. What happens next is, does the GP refer a patient with hypertension to a large asylum assigned to treat people with hypertension? We have two very stigmatizing services in Egypt. I'll tell you my experience in Egypt. Leprosy and mental illness. If a GP or a doctor suspects, that my colleague is having leprosy, do you know where they are referred to? Not to people who are specialized in dermatology and let's prescribe antimicrobial and stuff like this. We have something called the leprosy colony. A place called Abu Zabal, very stigmatizing as well, not because of leprosy. Abu Zabal is the most famous prison in Egypt. So they decided to have a colony. This is what's called Mustamara. In Abu Zabal, for some reason that I don't know why, where people with leprosy are put down there. If people with leprosy, not with depression or not with ADHD, were referred to a dermatology clinic in, let's say, in Lebanon, the American University Hospital, and you were seen by a specialist, it is not the solution for the problem, but it is less stigmatizing. This is why we're advocating delivering the service in the same way that we deliver to any other illness. And then we can have small center of excellence for tertiary cases that are resistant, like any other illness in medicine. This was my, proposal. The other thing is public awareness. is the key solution to any problem. But how can you compete with the media? The media is much, how to say it, stronger and influential than any lecture my colleague would give, or I would give, or you will give. A small YouTube movie would, how do you say it, reverse 50 years of fighting the stigma campaigns. So what we need to do is find the key opinion makers and educate them, and then make them the mediator of conveying the message. It's much more important than anything we are doing. I've been talking about stigma. I'm a professor in Ain Shams for the last 15 years. Every year, medical students, stigma and stuff like this. And then you go and watch one of the movies. A good doctor, thank you very much, and nothing changes. We have to have somewhere to deliver the messaging. But I totally agree that awareness, education is the key.
Beautiful idea, using the influencers to perhaps help spread the word and change that.
I just want to add like a personal experiences. So when we came in Qatar in about 2017, so I don't know if you're familiar with Sidra Hospital. So that's a tertiary care pediatric hospital. I think once in a lifetime experience basically over there, the type of hospital that it is. And the mental health department, psychiatry department was not the part of the initial plan. So we have new CMO, they say where is the mental health? They started recruiting people. And the prevalent thinking was that we do not need the child services, child mental health services, because there is no child problems in Qatar. And so in 2016, when we came over there, I think there were about 4 or 5 of us. In 6 months, we saw about 60, 65 patients. And in 2017, when we started looking at our budgets and all that type of stuff, and they say, see, we told you, there is nothing over there, only 65 patients, it's not really needed, your services are not needed. But we knew what you exactly said is that there is a problem with the stigma. There is a problem, what Dr. Hisham said very eloquently, is that there is a problem with the awareness about the mental health services. So then what we did is that instead of focusing in the hospital, we started focusing outside the community. So what we did is that we started reaching out to the schools and started providing the talks and started building the programs over there. We started engaging with the parents. We started talking with the Ministry of Public Health. And in 2 or 3 years, then it reached to the point, then they started doing the campaigns for all of the Qatar. For example, Are You OK was one of their campaigns. I think it was in 2020 in the World Mental Health Day. So it started becoming, now it become like a flood and flood and flood. From 65 referrals to 2022, when I was looking at the data of my division, we had, I think somewhere about 9,700 to about 10,000 encounters only in our outpatient, not counting the CL or ED or the inpatient services that we provide. Now we cannot stop the door. Now we can close the doors, and we don't know how we're going to handle the workload because people are coming and coming. And I'm talking also about their local population also. It's not only the expats are coming like a US and other people. Their local population also, because they are seeing their relatives whose kids got the treatment and their trajectory changed. They were going downhill, and with the treatment now they are doing better. They say, okay, well, this is a real science. This is real kind of like a treatment path. So now they are coming in. And so I think it is all exactly, it's the discussion in the community, it's awareness, it's you need to find a way to put the seed over there and give it about 4, 5, 6 years, and you will start seeing some of the results. The problem happens is that when you cannot provide the services. That's what you said. If the stigma go, what are we going to do then? Because then everyone is going to ask for the service. That's where budgeting comes. That's where human resources come, and that is basically the policymakers or the people who hold the purses. So,
thank you. We have perhaps time for 1 or 2 more questions.
Thank you very much. I'm Mayada Banaja, consultant psychiatrist from Saudi Arabia, newly arrived here in Emirates and working here. I would just want to share my experience and the idea of stigma. I started 26 years ago in psychiatry. Yes, I am. When I started as a resident, I had 2 patients as a new patient in psychiatry. One of them, he came, and the other one refused to come. Nowadays, I have 4 clinics per week. Every clinic is fully booked, and I have a 3-month waiting list. So this is the changes in the cultures about psychiatry. This is number one. Number two, I used to work in military hospital, then I worked in university hospital. There is a new trend, I don't know if you know it or not, to have psychiatric problem or going to a shrink is highly prestigious things. And every teens right now, he likes or she likes to have her own shrink and to have eating disorder, generalized anxiety disorder. What about panic disorder? It's something fancy. So this is some changes in the stigma from something that we don't want to have to something it is somehow prestigious. Maybe this is the idea of media that you said, the YouTube things. A lot of actress, a lot of actor, a lot of influencer has psychological problem and they present it. And this is why I have a lot of atypical eating disorder, atypical borderline disorder. And this is my area actually of interest. So we are moving now, and this is the thing we need as a psychiatrist, psychologist, to work on how we can protect our newly generation from attracting illness. How not to come. I have like 5 or 4 girls per day with suicidal ideation, and they think this is cool. So now we are moving actually from the stigma to other thing. On the other hand, the chronic illness, the admission, what you are saying, still it's, of course it's a stigma. Cancer is a stigma because it's debilitating and chronic illness. Diabetes is a stigma. Any other chronic illness that it's debilitating, it's a stigma. I don't think we can shift from non-stigma to stigmas. Either it's a psychiatry or not psychiatry. That's it. Thank you.
I totally support your opinion. My only comment is, even if cancer is stigmatizing, and it is stigmatizing, but people feel sorry for patients with cancer. I'll tell you our experience in Egypt. In Ramadan, it seems that people are giving, I would say, zakah and stuff like this, so they are donating money to everything. So people with societies fighting cancer would go and show you a patient with cancer and tell you we need money for research and stuff like this. And people would cry with them and give them lots of money. When we tried to do this with people with mental illness, nobody felt sorry for them. For some unknown reason, people did not cry with a patient with schizophrenia, and they did not donate money. Yes, please.
Although the cancer
It's a disease.
this is why we are giving people money for cancer. But
And this is
we are away from
the
that.
core of stigma, lack of knowledge leading to a negative attitude followed by prejudice and behavior that is antagonizing. So we still have to, we need to really make people aware. Mental illness is like any other illness. The problem with social media and people are now proud. I am self-cutting. I am like, I don't know what. We are facing it all the time. I have a relative, a young boy, and he started to self-harm and tell his colleagues, I'm going to kill myself. I thought his friends were going to leave him, and they will never talk to him. He's weird. Actually, no. He became an icon in the school, an icon with his friends, and people are admiring him for fighting and challenging this. So we have 2 different generations now.
Thank you so much. I think just because of pressures of time, thank you, Professor Rami and Afzal, for the wonderful presentations. Please bear with me for the awards presentation. Thank you, everybody. Thank you so much.
الله يكرمك الله يكرمك الحمد لله بخير تمام. لا انا التشير بيرسون دلوقتي هقدم الناس وبعد كده لسه في ابو ظبي. الله يحفظكم سعداء، سلمي لنا على الناس كلها ان شاء الله ان شاء الله. عشان مفيش وقت، احنا متاخرين نص ساعه كده، الناس عاوزه تمشي. Shall we start? Shall we start يا جماعه؟ انت بدات ازاي؟ حد قدامك؟ طب ممكن اقدمك انت كمان؟ لا خلاص انا خلصت. اسمك ايه بقى؟
تامر متولي.
دكتور تامر متولي، ماشي. هيثم شباب. Ladies and gentlemen, we'd like to, because we are ahead of the time, so we'd like to start the next session. First of all, thank you, Dr. Tamer Mitwalli, for being the chairperson of the previous session. You forgot to introduce yourself, so I'm introducing you. I'm Dr. Haytham Shabaik, consultant of psychiatry in Adam and Eve Medical Centers in Abu Dhabi. Proud and honored to chair this session in front of you. So we'll go fast. The next session, actually, it's a very interesting one, and I am personally excited to listen to that lecture or presentation. It is by Professor Farouk Majzoub. Professor Farouk Majzoub is currently an emeritus professor of clinical psychology, supervising doctoral research at the doctoral school of the Lebanese University. He obtained from the, and forgive my French, University de Picardie Jules Verne at Amiens, France, a postdoctoral diploma in habilitation, another time, forgive my French, de rigueur le recherche, right?
Thank you.
Okay, sorry. Actually, French is my third language. I only speak two. In psychology, clinique intercultural in 1999, and was a part-time lecturer at the Social and Behavioral Sciences Department of the American University of Beirut, AUB, from 1986 till 1990. He was a long-standing career and expertise with trauma assessment, reactions to trauma survivors, and stress management, and was elected since 2001 to a member status of the American Psychological Association, APA, and since 2007 he became member of the European Association of Psychotherapy, EAP, holding the European Certificate of Psychotherapy and le Certificate Français de Psychothérapie, given by la Fédération Française de Psychothérapie et Psychanalyse.
Thank
Right?
you. Thank you very much. Thank you very much.
Forgive my French.
Thank you.
Please welcome with me our Professor Farouk Majzoub. Thank you. Please.
And I'm very happy that you are here to share with me this really experience of disability, deafness. And mind you, I had my cochlear implant surgery 4 years ago. That means I spent most of my academic life and my teaching career, supervising, I was somehow totally deaf. So I want you now to share with me this. It is really, I was always wondering how could I stay all these 30 years with total deafness. It was something really, for me, I always question this now, because in fact, spending 30 years teaching at the university and also practicing psychotherapy and supervising, it is not really something easy. In fact, one suffers a little, but I always was somehow overcoming this. It is a story of deafness, but in fact, I call it a story of love. Because this love that we needed from the time we are born till we die, in fact. So let us speak a little about this really hearing process. Where is this?
Forgive me, Dr. Just, I forgot to say something. Professor Farouk, the title of the session,
sorry, yes.
which is very important to mention because this is the challenge we are all gonna listen to right now. The title is...
No. Hearing, in fact...
No, it's not French, thanks God.
Wireless,
thanks God it's not French.
Communication. Where spoken words and ideas are passed from one person to the other by pulsating air molecules striking the eardrum, which activate the bones of the middle ear.
The title of the session is When a Psychotherapist Keeps on Dealing with Hearing Clients During 30 Years of His Total Deafness and the Auto-Healing Mechanism of the Emotional Brain. Please welcome again Professor Majzoub.
So the hearing takes place when pulsating air molecules striking the eardrum, which activate the bones of the middle ear, which then cause the fluid-filled cochlea to experience wave motions, which bend the hair cells, which send neural impulses up to the brain. So hearing, in fact, thus this wireless mind-to-mind communication follows a complex procedure, starting from the outer ear's air pressure waves collected to the mechanical waves of the middle ear, to the fluid waves of the inner ear, to the electrical waves pulsating up the auditory nerve, where finally the words and the ideas reach the brain. Hearing is disturbed when anything goes wrong at any one of the above complex stages. So, now, the assumptions about disability. There is disability, but not disabled person. In fact, disabled person, it is too much. That means he is incapable. And I don't think there is someone incapable unless he is either dead or something else. And the ears are deaf, but one can listen through his heart and eyes. This is why I attach great importance to really this watching. I mean here the what I call it the nervous system, the brain aping, which is really the mirror neuron cells are very important in really somehow when they are activated, they are important to really somehow teach the person. So we are disturbed or delighted, not by events, but by our judgment about those events. These are Epictetus, Manuel Epictetus, what he was Stoics, and in fact, he has preceded cognitive behavior psychology long time ago, because he attaches importance to the wisdom, to acceptance and commitment, which is really very important nowadays in cognitive behavior psychology. People are driven by a need to feel that they are significant and that they belong. And this is also, it is related to attachment psychology, because belonging, the need to belong, is really start from the beginning with the child and later with the adult. They always want to be recognized by others. Now, the brain is of biopsychosocial nature. It is really, I attach great importance to the social nature of the brain. Sorry. Now, the human ability to sense the internal state of the another may rely on a system of neurological circuitry called mirror neuron system. This is really, to me, this is very important. I really learned many things through watching. And I told you that I was a music fan. I liked to listen to music, classical music, ballroom dancing music. These were really my hobbies. And maybe these were, again, some asset for me to continue to love life, There is a functional connection between the visual, the emotional, and the motor. We cannot, when you see, you are motivated. You see, we cannot, and they belong, in fact, to the superior colliculus, which is also a visual and emotional center. Sorry. And this is my education, which is really somehow extracurricular activities. I was an active member at AUB Music Club and enjoy going to AUB dancing parties, training in psychotherapy, and I took an elective course in classical music, And classical music, it is something spiritual. We all know, or you have heard of Sebastian Bach, his toccata and fugue. You have to concentrate, and concentration, it is like attunement to oneself and also to the other. Now, getting married, honeymoon, okay. You see, I told you, I never went to a dancing school. Simply, I like to dance. It was really, the rhythm is in me, you see. And after all, life is rhythmic. And this is why I learned this through watching. That is, at that time in Lebanon, in the cafes, there were bands, and they play music, and people, they go dancing. So I watch so as to be able to apply, you see, simply. It is really, this is very important. And this is why I believe in mirror neuron system, which helps a lot in learning. Okay. Now, pursuing higher education in Paris, la tolérance à la frustration chez les adolescents libanais en psychologie clinique approche projective. I applied the TAT and the Rosenzweig picture test, which both are projective tests. This is a Rosenzweig picture test about frustration tolerance. In fact, before becoming deaf, I was so much interested in frustration tolerance. You see, which is, I don't know why. And they used to call me le frustralogue, because I used to go to a center of delinquents where I can find so many documents about frustration and the cause of delinquency. So expertise in the field of frustration mechanism and frustration tolerance. Now, experiencing sharp, sudden drop of hearing in one of the two ears. This was a catastrophic shock. In fact, I couldn't imagine that. I was suddenly, hospitalized, getting enough treatment. They told me nothing is wrong in the brain, but it is simply a sudden drop of hearing. So I went to another doctor. He was very reputed for treating ear and was chef de service. He was chairman. He told me, let us try hyperbaric oxygen. Hyperbaric oxygen, in fact, should never be given to anyone who is suffering, who has lost one ear. I remain one ear, you say it remains here. How could he apply this? So he boasted, because he is really a chairman and a chef de service. So he said, and he works at military hospital, that he is really giving me a favor. So I obeyed him, and I went, when I was under the pressure, I went out of the caisson losing the two ears. The two really no more hearing at all. So it was really a great shock for me, and I couldn't believe that. So he put me to a clinic, private clinic that he works there. The clinic it was run by none. And in fact, again, in the clinic, I got another shock from the medical per os. It was given to me. And this really was a catastrophe. I got two shocks. One from the hyperbaric oxygen, second in the treatment, which is really cannot be given. And all doctors really condemned this type of treatment, because they said it can never be given to anyone who lost somehow drop of hearing in one, and you give him now, you take the chance, because the hyperbaric oxygen, they give pressure, and then they diminish the pressure, and then they augment. So this is now. This is about the doctor. Okay, hearing was regained gradually in one ear, but the ear I felt it was already dead. But yet I could hear. I said, okay, thanks God, I am able to hear more now. I can go on. Sorry. Back to Lebanon, you see, I pursued my teaching and supervising career as a full-time associate professor. You see, this was a helpful for me. That means I forgot. Somehow, I am no longer, I don't think of the ear now. This reminds me of the psychiatrist. This is logotherapy. Logotherapy. The psychiatrist Viktor Krenfel, he talks of really that one is not supposed to think of the problem. He is supposed to really focus on something else. It is a kind of de-reflection, in fact. So here, 6 years later, I was teaching at AUB. It is the university where I graduated first. And sitting, and by coincidence, I was giving a course on hearing, abnormal psychology. So suddenly, I got this loss of hearing totally. And here the problem began, you see. The aping brain, in fact, the cause of any pain, in my opinion, lies mainly in the brain. The brain has an extraordinary mental capacity for simulation, a functional resemblance. You see, this is to make, let us say, photos of the things, whether for others or for its own self. Brain structure is endowed with mirroring cells, which enable the brain to represent in the visuomotor brain something which is not taking place in the brain and the body. So this is really something very good, you know. The origin of the self is to be found in the basic neural circuits of the superior colliculus, which is connected to the emotional and motor centers of the periaqueductal gray, that is, the forebrain emotion. See, emotion mediating structures such as the amygdala, the motor, and the sensory areas. This is a very rich area. And this is the superior colliculus is also a visual center, you see. This is why I attach great importance to the mirror neuron cells. You see, this is something. The brain's mirroring cells are behind many aspects of behavior modification. After all, we all talk of vicarious learning. What is vicarious learning? It is mirroring, you see. This is why, and are activated in a way or another during all relational activities which express our core being. One experiences the world through his own body. And our bodies constantly survey our environment looking for markers of safety or threat through a process designated by Borges and neuroception. In fact, now you are altogether affecting me. We have a kind, let us say, communication. This is energy. Sometimes we say about a person, he is تقيل الدم, you know. We cannot tolerate, you know, without talking. So you are communicating now energy to me, and I am also communicating energy to you. It is something, you know, we live in a cosmic energy. So this is where attention goes, a neural firing occurs, and where neural fires, new connection can be made. This is something really experienced by all. Attunement, it is very important. You attune, that means you feel the others what the other is feeling. And this is very important in psychotherapy. Because, and this is, after all, I learned this from music. In classical music, we have supposed to really reflect, think. You see, when we listen to Vivaldi or to Beethoven or to anyone, any composer, we always somehow, we have to concentrate. This concentration is a gift. We are able to, this enables us to somehow to understand the other. In therapy, we have to feel that the other is feeling what we are really feeling. This is synchronization. In dancing, it's the same, especially in ballroom dancing. You see, there is this synchrony. You try to, when he really performs a step, a movement, you really react. So this synchrony is very important. Synchronization is the basis for therapy. You see, attunement is a process that tracks the moment-to-moment changes in the somatic, emotional, and energetic rhythms of oneself and others. Okay. Where is that? Okay. When the brain rhythmic structure is highly functioning in the life of a psychotherapist, but, you know, he got really a problem, is blocked later from expression due to a particular physical incident. This might be invested in other avenues, which are kinds of rerouting the neural circuitry. Now, I tried, what can I do? So there was a kind of now rerouting my really, let us say, my old habits, etc., to something else. See, there was a consensuality that being totally deaf is behavior handicapping. It was really, okay, I am deaf, but what can I do now? So, but on the other hand, there was a degree of subjectivity on how deafness was appraised in the light of my personal resources. And this, I go back now to Epictetus' manual about that the things depend upon what we judge, but not upon really the thing itself as such. So, and I told you this is really, I emphasize Viktor Frankl, psychiatrist, who really talks of derealization, and he talks of really creating sense to life. So I have to create sense to life, and this is why I was involved and indulged in studying, in achievement, etc. And I tried to get my postdoctoral degree, etc. All this now we can say compensation. I really loved that, but at the same time, you forget about that. This is my destiny. So we can say that is life. People, they really live like that, and others, they have worse situations. So the exploitation of personal, cultural, educational resources, which constitute an asset for personal growth, self-image, self-esteem, social and academic skills, and interactions. Okay. Just now to tell you, I chose a student from the class to really write for me when I teach, and to write the student questions and also their answer. But sometimes I could know the answer and the questions without really, because I know I asked the question. I expect this and this answer from the students. So students, sometimes they thought that I really start hearing. No, it's a matter of really expecting. So all these are really what achievement, okay, overcoming deafness, okay, to what all those are, okay, achievement, okay. This is appointed as member, okay, France, granted a title of professor from the dean of the University of Picardy, etc. This is in France. Now, the auto-rehabilitating factors, the emotional brain possesses natural auto-healing mechanisms. It is a matter of innate capacity to regain the balance and well-being. This innate capacity is like other auto-healing mechanisms in the body, such as wound healing and elimination of infection. This method, which passes through the body, takes full advantage of these mechanisms. You see, this is very well known. Trauma, after all, but not in the abstract, there is the interaction between the external and the inner. After all, the brain is an open loop. See, and this is, it receives and interacts. Trauma researchers and clinicians have been recently emphasizing the holistic approach, using less verbally intensive treatment modalities for trauma survivors involving body movements, creative arts, and this is what I apply usually. I apply this really holistic approach because, in fact, only the body tells the story, not really. So negative feeling, guilt and shame and all anxiety accompany trauma survivors can be reduced by music ability to activate reward pathways in the brain and suppress the release of stress hormone. You see, music is sound. A sound is rooted in vibrations absorbed through the body that can heal from depression, enhance pain tolerance, and anxiolytic properties in reducing pain. So music is very important. This is why I emphasize this. You know, involuntary music imagery. We can imagine music. You know, you can dance if you are told that this is the paso doble or the tango or anything else or salsa. Sure, you really sing it in your mind, and you visualize and you start making the steps. This is possible. You know, motor movements are necessary for cardiac development, brain's cortical network for consciousness to emerge. Now, okay, dance involves neurobiological processes in 7 brain's areas, such as cognitive, social, emotional, rhythmic, and creative. This is very important. You know, you are moving the body. Now we really we tell the let us say the geriatric, the old people like me, you see, to really move, so as to keep on having this really. Now, dance is okay. Deaf people can feel music. visualize music and dance to music. I put my hand over, I used to tell my assistant to put this type of music. I put my hand over the radio, I hear the vibrations. So this will really, I could, even when watching tennis, I like to watch tennis. When I watch tennis, when the ball taps the floor, I hear, I don't know how, the vibrations, you see. Now, okay. Are there some gaps in the choice of professionals working in rehabilitation? In fact, according to the Center of Disease Control and Prevention in the United States, 1 in 4 adults has some type of disability. You see, this is too much. But now we have to change the definition of disability. It is something more. So I know with the wars happening and what we are witnessing, it is really, no, this is disability. Take it, Maras. No questions for me, I see. An overwhelming majority of health providers working with disability have a biased view toward disability, which contribute to inadequate health care. So many, they care only for the symptom. But there is something else. They have to think for the things in the disability, but not in the only apparent symptom. And so many, they go into the study, into rehabilitation, simply because I don't know how much they are interested in this. Following TACIT, most rehabilitation professionals identify themselves with rehabilitation psychology after training in clinical neuropsychology and health psychology without having sufficient exposure or preparation to the field of rehabilitation. And this is really a dilemma, in fact. Now, positive aspects of the person suffering from disability are supposed to be really to pay attention to. The strengths, if not detected in the person suffering from disability, it can be cultivated through his self-image, self-esteem, social skill, interaction. Interaction is very important for him. Yeah. So strengths, okay, can be detected. Okay, encompasses sources available, the parents, as I did myself, let us say. Okay. The above-mentioned strengths relevant to the person suffering from disability are assets for him to cope with stress and provide evidence. Thank you, thank you, thank you. A question now. Anyhow, who has a question, please write it to me and I can...
Hello. Thank you very much, Professor Majzoub. It was a very interesting presentation, and what I can do is only hats off for you for all these challenges, and please a big hand for Professor, because this is a life challenge and he succeeded in it and he reached to the top level of that kind of challenge. And now he's speaking in front of us, teaching us about his challenge and teaching us about the depth that he experienced. So thank you very much, Dr. Majzoub. Because we are ahead of time and we are very late, actually, we are till now like 30 minutes late, and we have another session after our session. I'd like, we will delay the questions and answers till the end. Yes, of course. After the 2 sessions, after the second session of Dr. Abdulazim, we will take questions. I would like to welcome Dr. Abdulazim Mahmoud Mabrouk, consultant pediatrician at Saha and associate clinical professor, College of Medicine, Al Ain, UAE University. Dr. Abdulazim is a consultant pediatrician and clinical associate professor in Al Ain. His main fields of interests are general pediatrics, child developmental and behavioral problems, nutrition, obesity, asthma, enuresis, ADHD, and school health problems. He is regularly conducting primary care services in these fields in Al Ain. He is actively involved in teaching and examining medical students, interns, and residents in the fields of pediatrics, psychiatry, and family medicine. Dr. Mabrouk was awarded the Excellence Teaching Award in the College of Medicine, UAE University, and Saha Excellence Award for Best Practicing Doctors.
He regularly presenting in scientific conferences and participated in several researches studying the common childhood problems and has many published papers in national and international journals. Please welcome with me Dr. Abdul Azim, and we'll listen to his presentation by the title of Psychosocial Aspects of Child Illness. Thank you very much.
Good afternoon, and thank you for the kind introduction. And this presentation will be like just our experience. In Al Ain, we had a joint pediatric and child psychiatric clinic for a long time in Al Ain. And just I will show you some of the cases which we saw and some of our publications. The objective are to discuss psychosocial aspects and multidisciplinary concepts in management of childhood illness, and to demonstrate clinical case scenarios and elaborate on national UAE school health mental screening program, and to present our research work and implication to practice and conclusion. We know that psychological well-being and coping in the context of chronic illness is challenging for children as well as families. And behavioral science research in the last few decades has significantly advanced our understanding of the psychosocial issues in the context of childhood illness. However, these issues vary from one culture to another, so the need to study and apply these factors locally in each community. And there are some problems with psychosocial care in pediatric practice. The parent response, parent needs psychosocial support and event treatment. And there is defect in education about childhood problems, and there is a lot of child abuse issues. And the doctor response, limited clinical experience, training limited, unaware of prevalence, few clinical guidelines, limited and fragmented evaluation services, and failure of identification of developmental, mental, and behavioral problems. And here there is changing concept. The rapid socioeconomic change lead to changing child health problem and changing the management concept. UAE economic boom and rapid socioeconomic development significantly impact on the young generation. This country is one of the most developed countries in the world. In few time, there is a very significant development. So this leads to change the pattern of child health problems from a developing problems to a developed problems. And there is a transitional area also. So you will see almost many cases of survivors of previously fatal conditions like malignancy, preterm babies, organ transplant, a lot of behavioral problems, ADHD, anorexia nervosa, developmental disorder, learning problem, language delay, autism, road traffic accidents, obesity, drug abuse, smoking, and also there is a lot of drug abuse and drug addiction, and now there is media addiction also. So I will just present some cases related to our research and the implication to practice. The first case, an 8-year-old boy with hyperactivity, impulsivity, inattention, and learning difficulties observed in the classroom and at home. And the most difficult of 3 children at home. Always being very active and never get tired, never finish any activity, rushing to finish his homework or leave it unfinished. This is a typical problem with ADHD, and this is one of the commonest cases which we saw in our clinic. And usually we said when we see a child with, I don't know what is happening here. a child with ADHD look at the parents, especially the father. It is a genetic problem. This is, we developed a national UAE mental health program, screening program for school children. And it covers most of the behavioral problems. And usually we use this questionnaire, we put it in the file of the health file of school children. And all grade 1, 5, and 9 children will be screened for this, and whatever there is a concern. And here in question 10, there is a specific question about ADHD. And this is the action plan. And when you have any concern about ADHD, this usually filled by the parents, and the nurse in the school will fill this, and if there is any concern, a corner test will be given. Like that child which I present, his corner was 18 by the school teacher, and by the parent it was about 29. And he fulfilled all the DSM criterion for ADHD. And he was assessed by the educational psychologist who recommended medical and behavioral therapy. And this is part of, we have a lot of research project in Al Ain, and this is one of the papers which we published, epidemiological study of attention deficit hyperactivity disorder among school children in the UAE. The rate of ADHD by Connor report parent, it is 4.1. By Connor teacher, it is 3.4%. And children with ADHD have a range of psychiatric comorbidities ranging from anxiety, depression, withdrawal, somatic complaints, social problems, thought problems, attention problems, delinquent behavior, aggressive behavior, other problems like internalization and externalization. Our findings suggest the importance of comprehensive and early ADHD screening programs and the need for designing intervention. This is a second case, is a 6-year-old boy referred with daily bedwetting. This is the commonest problem in school children, which we saw. The child has never been dry, still bedwetting at age 6, deep sleeper, positive family history, and poor self-esteem. Typically, this is a presentation of primary monosymptomatic nocturnal enuresis, which is a very distressing to the child and parents. Parents endure extra workload and expense, and children may suffer a significant lack of self-esteem, shyness, isolation, and anger. This is one of the renowned English novelists describing his self-esteem. He was a bedwetter, weak, ugly, unpopular, chronic cough, cowardly, and I smelled. Also, the emotional impact. I was a bedwetter, which is miserable at boarding school. He was named the clown, the Biddler. Kids tease him for anything. Also, this very famous American singer and actress. I remember going to the camp with my brown rubber sheet. I was a bedwetter until I was 7. I was so impressed at the camp. This is the commonest problem which we saw in school children, but most of it is not coming for medical attention. In our questionnaire also there is a question about enuresis, and also in the action plan, and we have a questionnaire. The main importance of this questionnaire is to design it if it is primary or secondary. This is some statistics of from our enuresis clinic. Many children do not seek medical advice. Hidden problem, stigma. There is a lot of stigma about this. In 1 year, we saw like 372 patients. Most of them are boys, and most of them are at the age between 6 and 11. But very important group is those who are more than 15. This is a very important group. Sometimes a girl with 20 years will come to the clinic with enuresis and never seen a doctor before. This is our study prevalence and correlate of nocturnal enuresis in the UAE. Prevalence, we found like 8% more in boys, 80% at age of 6 to 11 years, associated with positive family history, poor scholastic performance, presence of psychological disturbance. Our findings suggest that bedwetting is a common problem among a common problem with school children. They need to be screened for associated psychotherapy. This is the third case, another very common problem we used to see in the clinic. 15 years old girl referred to obesity clinic for evaluation. Her weight is 143. This is at age of 15 years. Height 161 and BMI 55. She had most of the complication she developed at this early age, most of obesity complication. Extensive acanthosis nigricans, insulin resistance, type 2 diabetes of the young, hypertension, dyslipidemia, metabolic syndrome, liver disease, non-alcoholic fatty liver, polycystic ovary, psychological upset. Her depression scale was very significant, and she was very depressed. And this is a very unattended problem in children with obesity. So this child has acanthosis nigricans in all her body. This is our study. This is the prevalence of obesity in UAE. It is about 20%. Overweight 14%. Boys more than girls. So this is a very common problem in children. And there is a strong association between adolescent obesity and depression. This is our study. We found the rate of metabolic syndrome about 44% in our sample. And the psychological distress reported is 95%. And there was significant depressive symptoms, 76.9%. So obese adolescents should be screened for associated complications and target them for early intervention, including attention to psychological issues. The fourth case is a 5-year-old girl newly diagnosed type 1 diabetes, referred suspected of insulin allergy. She was on intensive insulin therapy, injecting 4 times a day, and blood testing before each injection. So a lot of injection. Parents anxious, sad, when insulin injected, cried, sweated, palpitation, pallor, became frightened, no rash or wheezing. So this child has severe anxiety with panic attacks with needle phobia, which is called trypanophobia. This is a common problem with diabetes. This is our study, a controlled study of psychosocial factors in young people with diabetes in the UAE. Patients perceive themselves more negatively, more in girls, lower scores in physical appearance and athletic competence, positive self-image associated with better maternal education and social support. Parents exhibit behavioral and emotional problems. Psychosocial problems common among diabetic children and their parents. Diabetes management should involve parent support and involvement and appropriate psychosocial intervention for children. This is a 10-year-old girl with acute lymphoblastic leukemia, early involvement of CNS, 4 relapses, previous bone marrow transplant, no further medical treatment is curative. Parents so upset and depressed. So she needs psychosocial management of child and family. We studied this, and children with cancer, we found score themselves more negatively in all domains. If we compare with diabetes, score themselves more negatively in areas of physical appearance and athletic competence. Family coping, parental hope, social and family support are the most important factors contributed to better coping in children with cancer. And healthcare providers should be aware of family coping, understand domains of self-competence and self-worth, offer appropriate psychosocial intervention for children with cancer and their family. This is a 16-year-old girl, morbidly obese, and she had strict dieting regime, strenuous exercise. Her body image was disrupted lost significant weight. In like 3 months, she lost like 15 kg. Tired, exhausted, girl said that in the school she had HIV and referred to the clinic. So this child has scored above cutoff of EAT-40 test. She has eating disorder and anorexia nervosa. In our study, we found 23.4% of girls in the sample scored above the recommended cutoff of EAT-40 test, and 2% met the criteria for the full clinical eating disorder syndrome. Our findings suggested that around 1/4 of the secondary school girls have disordered eating attitudes and behavior. Attempts should be made to screen and identify these adolescents and target them for early intervention. This is an 11-year-old boy with tics and OCD. Deterioration in scholastic performance and memory, hyperactive, impulsive, emotional ability, had secondary enuresis, positive throat for beta hemolytic streptococci, and high ASO titer. What is the diagnosis? This is a neuropsychiatric symptom preceded by upper respiratory infection. This is what is called BANDAS. It is pediatric neuropsychiatric, autoimmune neuropsychiatric disorder associated with streptococcal infection. We have a case series of these children presented with abnormal movement preceded by upper respiratory infection, psychiatric symptoms, OCD tics, and high ASO titer, positive throat culture. And BANDAS is relatively a novel disorder that brings mental illness to its biological roots. Group A, beta hemolytic streptococci, trigger an autoimmune reaction in genetically susceptible children, leads to development of neuropsychiatric symptoms, and should be suspected in any child with tics and OCD that is exacerbated after upper respiratory tract infection. This is a child.
Doctor, because of the time, please, just 2 minutes, please.
Okay.
Thank you.
This is Hashimoto's thyroiditis. In our series, we have 10% with children with goiter has Hashimoto's thyroiditis, and half of them showed feature of depression. So Hashimoto's thyroiditis is not uncommon in adolescent girls with goiter and should be screened for depression. And this child with autism, now autism prevalence is very high, and the latest one in 36 last March. And in our study, we find in the first stage, 58 per 10,000, and in the second stage, 29 per 10,000. So children with autism are not adequately detected in available screening program and need better screening. And this MCAT, which we give to all children at age 18 months in the Well Baby Clinic. This child with a new technology and internet addiction disorder, which is a new syndrome defined as compulsive urge to continually use the net, whether it to be spent hours surfing the web, hang around in chat rooms, or playing the game. Now, this is a very important issue in children. And we studied these children. We found that involvement with TV video game time for more than 2 hours per day observed in 37% of children, associated with more childhood behavioral problems, including social, attention withdrawal, delinquency, aggressive behavior, internalization, and externalization. Counteracting negative effect of involvement with TV video game in children requires increased parental awareness. And in conclusion, psychological well-being and coping in the context of chronic illness is a challenge for children as well as their families. Our research work indicated that behavioral disorders are not uncommon problem among school children, and there is an urgent need to initiate a screening program for such problem and design appropriate multidisciplinary intervention. You need more training, screening, research, and teamwork. And thank you very much.
Thank you very much, Dr. Abdulazim. Sorry for the rush once more. It was a very interesting presentation. We would love to take it on a more longer duration, hopefully next time. Now, because of the time as well, we are going to take 4 questions only, 2 questions for each speakers. So if may the speakers please come up on the stage. Doctors, please. Would you like to keep seating here? For Dr. Majzoub, anyone would like any question, please can you write it down on a paper, please? Okay, you can sit here, no problem, it's okay. So, any questions, please?
Thank you, Doctor. Overall, can we say that there is a high correlation nowadays in pediatric children comorbidity with psychiatric disorder, and how related it is to the eating habit, the school, the psychosocial effect as well? Like, for example, the nocturnal enuresis or the TV hours addiction or whatever you want to call it. Do you see any higher correlation, psychosocial, inducing the medical disorders that you described?
I think there is an interaction, the two problems, the medical and the behavioral. Many children with medical problems has a lot of behavioral issues, like diabetic children, for example, like a lot. But this is not well taken care of. People are not taking care of this. And for us, we used to do this clinic in a school health setting, school health clinic. And that is how we overcome the stigma and these things. A lot of children and parents will bring their children to the clinic because they don't want to go to psychiatric clinic over here.
Thank you very much. Dr. Talat, can you tell us the question, please, so that you gave to Dr. Majzoub?
It is not a question, but just I would like to express my...
Yeah. Who would like to speak, you or him? Okay. Yes. What do you want, Mike?
Say thank you, Doctor, for the beautiful lecture. Okay. Now I understood how Beethoven was composing music while he was deaf. This is true. This is, music touches the heart. And I said one can listen to by his eyes and heart. You can sometimes hear, but you don't listen. So what is the cause? What is the result for? So about the device, maybe this is really, now there is a device which transforms spoken words to written words. Have tried this? No, I never tried this device. My device is my heart and my eyes, believe me. It's always like that. See, I think one can, deafness, if you really have an interest, if you have a hobby, I ask my student usually, the first question he comes as a client to me, I ask him, what hobby do you have? You see, I attach great importance to this because this hobby gives meaning to his life. You see, this is something very well known. So, depending on the device, no, let us always depend on really something from his inside. So he will enjoy more maybe, I don't know. Because in the device, he is passive. He is passive. But now when he is supposed to really listen to the other, he is supposed to give his eyes and to synchronize, He cannot synchronize. In therapy, it is based on synchronization and on mental this attunement. Attunement is very important for any person, not only for people who are deaf, you see. Because we are dealing sometimes with people deaf emotionally, and therefore we have to attune with them and to feel with them what they feel, you see. Otherwise, the whole job we have is nonsense, believe me. I tried more than 20 years psychotherapy, dealing with supervising. I had three groups, they graduated. One of them is behind me, you see. She took a group therapy. And I could feel their feelings, you see, and they came to me because they really heard about me and they really appreciate me somehow. I don't know. Besides, in individual therapy, I used to tell them, please write what your problem and read it somehow loudly. So when he reads loudly the issue, that means he looks at me, he feels that I am validating his problems. The problem that he was not there, the problem is a problem because no one is really feeling with you. No one is validating what you really behave, what you do emotionally, etc. So when he comes to me and I listen to him, you see, and I tell him write and read. So it is really, I found this technique is very successful, believe me. This could be applied not only applied by anyone, you see, not only from a deaf to the other, no. I don't know. If you have another question, please.
Thank you very much, Dr. Majzoub, for this very clarifying answer. Another question, and the following will be the last.
Assalamu alaikum, Professor Abdul Azim. Thank you so much for this nice lecture and talk. I think it's very nice to see a data coming from the country and research for all the field of neurodevelopmental disorder. My question about it's very lovely also to see integrated pediatrics with the child psychiatry. So my question, is there any program for screening along with immunization? Because the immunization is the first point that the child will go to the PHC center. And if there's any training for the nurses, because the nurses, they're the one who is seeing the patient, taking their weights, maybe they will take long time for observation for these childs during the immunization. They see them frequently, maybe from day 1 up to 18 months or and so on.
Yeah, regarding training, for this program, the National Screening Program, Mental Health Program for all nurses and doctors in the UAE were involved and trained. There is a training, all of them have been trained to take this program. And I think this is very important. And the other thing for screening your well baby child, now the only screening test is what I show you, this MCHAT at the age of 18 months. All children coming for 18 months vaccination should be screened. This is a screening test, not a diagnostic test. This is the most important thing. Every child should be screened for this. And this is covered by insurance, and there is a code for it. So every child coming for 18 months in the UAE should be take this questionnaire.
Last question for over here.
Thank you, Dr. Abdulazim, for your talk. I think it gives us a lot of richness to the research background that you brought to this talk, and it makes me think how this interdisciplinary speciality-based research that you've done, how do you approach sort of bringing together two specialities in this case? From a research perspective, I think there may be a lot of challenges that you may have come across approaching pediatricians and child psychiatrists for research. So any advice on that, on how you can bring together such collaborations?
I think that was like a project research program between the university and the Ministry of Health. And the most important research was funding. So we have good resources, and we use the nurses in the schools, in the primary care, in the hospital, and the primary health doctor, and this thing. So this can be managed. But if you start, you have to have a plan. Okay? And the good thing about this research is we have this Sheikh Hamdan Award. We got it maybe 2 times for this project researches. So you can do it. But you need a lot of people to work with it.
Thank you very much for our distinguished speakers and for the audience. Now it is the last section of our section, which is awarding the speakers. So please, if would you like to come up, doctor, or would you like to have the award here? It's okay.
ساعة تأخير السيشن اللي قبلينا أنا حافظت على التايم وحافظت على نص ساعة تأخير ما زودتش.
Assalamu alaikum. Our next lecture will be about the use of the artificial intelligence in the dementia care. Our speaker will be Dr. Hamad As-Sinawi. Dr. Hamad As-Sinawi is a senior consultant old age psychiatrist in Sultan Qaboos University Hospital. Dr. Hamad graduated from Sultan Qaboos University Hospital, then pursued further training in old age psychiatry in the UK, and he obtained the FRC Psych. He returned to the Oman to set up a memory clinic at Sultan Qaboos University Hospital, which is responsible for the assessment and management of patients experiencing cognitive symptoms and training medical students and psychiatry resident and supervising research projects. Dr. Hamad has several publications in the high impact journals and He has authored several book chapters in different areas of psychiatry. Dr. Hamad is the rapporteur for the psychiatry program at the Arab Board of Health Specialties and has been involved in developing training standards and policies for the program. And he serves and involved in developing examiner, and he's as examiner for the clinical part of the Arab Board as well. Dr. Hamad is passionate about raising public awareness about mental health and addressing the stigma, and also he was awarded a Best Public Educator by the Royal College of Psychiatrists in the UK in 2014. Dr. Hamad is also the chairman of Oman Alzheimer Society, which is a non-profit organization working with people with Alzheimer and their caregivers to raise the public awareness and improve quality of service for people with cognitive impairment. Please welcome Dr. Hamad.
Thank you, Dr. Ali. Assalamu alaikum wa rahmatullahi wa barakatuh. I'd like to start by thanking the organizers for inviting me. It's always a pleasure to meet like-minded people and talk about interesting topics that we can exchange knowledge and experience about. So you've probably been reading a lot about ChatGPT and artificial intelligence, and it's probably became an obsession to a certain group of people. So I thought, why don't we take this obsession a different level and look at or probably review how can artificial intelligence help us in a specific area, which is an area of an interest to myself, which is dementia care. So I start by saying that I don't have any conflict of interest. I will be describing few programs, but I'm not sponsored by the companies. It's purely for academic reason. These are my learning objectives. So we'll start by giving an overview about the term dementia. What is the latest kind of criteria? What are the figures around the world? How is the situation in the Arab world? Because we are going to tie it up to the GCC country and the MENA region. We will also then develop the idea of how is AI used in healthcare in general and how can that be useful for people who have cognitive impairment. We will discuss a few examples of how can we use AI through the care pathway at a different patient journey, and we will conclude by describing some ethical challenges and future perspectives. So let's kickstart by definition. So you are all familiar with the term neurocognitive development that was introduced by the new DSM-5 at that stage because people thought the term dementia is stigmatizing. So the new term is neurocognitive impairment, and the main features are things like a person would have complex attention, problem maintaining attention, doing complex tasks at the same time. So multitasking will be a problem. A person cannot drive and listen to the radio, for example. They will have problem with the executive functioning. Planning a simple task would be very challenging. Going shopping, for example, knowing the steps of how do you get there and how do you don't get distracted when you are meeting somebody in the shopping mall, and remember that you would say goodbye to the person, then you carry on with the task you have in hand. A person will have problem with learning and memory. So forming new memories or understanding or learning new tasks would be difficult. So a person might get an upgrade for the mobile phone and they find it completely challenging. So a simple thing like making a telephone call with a new smartphone will be a challenge. Language, understanding and using language will be impaired, and also issues with motor and social cognition. So these symptoms will develop gradually, most of the cases, and have to exclude that this is not happening as part of a delirium, for example, if somebody has an acute medical condition. Now, dementia, best seen as an umbrella term. We often get people asking what is the difference between Alzheimer's and dementia. This includes people who are in the governmental authorities where they are responsible for giving certificates or certain social benefits to patients. So we say umbrella is dementia is an umbrella term, or like a tree. And out of this tree, we have different branches. So the biggest branch is Alzheimer's disease. Most people think Alzheimer's means dementia. So we kind of explain that. So I would say Alzheimer's-like. So Alzheimer's is the most common type of dementia. Up to 80% of cases with Alzheimer's of dementia are due to Alzheimer's disease, followed by Lewy body, vascular dementia, frontotemporal dementia, and other kind of less common dementia. So understanding this beginning is very important. So what is common between all those symptoms? That the person will have problem with making memory, social behavior, and personality changes. Few statistics here, and according to World Alzheimer's Association, number of people around the world estimated to have dementia in 2020 was 55 million. This is expected to reach 252 million by the year 2050. So you can understand that this is going to be a challenge to most countries to provide services, to have a program of early diagnosis and management, and providing both social and health care. In one estimate, it says that in every 3 seconds, somebody develops dementia around the world. So that's a very scary thing. So how long have we been sitting here? So if I'm talking to you within half for 30 minutes, how many people around the world will be developing dementia around that time? It's a cost-linked condition. Most of the cost is borne by the family. We call them informal caregivers, especially in our region of the world, where a person with Alzheimer's will be staying at home. Somebody, wife or a husband, daughter or son, will step in to become the caregiver. But in general, it's a costly condition. It's estimated around 1.3 trillion cost. This is all estimate again, and expected to raise to around 3 trillion US dollars. So we're talking about a big chunk of money. Problem is that people hold negative attitude, so stigma is a big issue. 2 out of 3 people believe that it's normal part of aging. And this is a big challenge when it comes to detecting the symptoms and hence seeking early diagnosis and management. And the scary part is around 70% of people with Alzheimer by the year 2050 will be living in our part of the world. So developing and middle income and developing and developed countries. So again, this is going to cause lots of burden to healthcare systems. So the situation in the Arab world, the prevalence varies. So obviously younger onset dementia by definition before the age of 50, which is mostly kind of Alzheimer, familiar type, or frontotemporal dementia. The prevalence is around 1.2 to 2.3. This increases when the person grows up. So after the age of 80, the prevalence is as high as 18.5%. Most cases are Alzheimer's, and obviously female are more likely to develop Alzheimer's. And that's an article we are in the process of publishing with my colleague, Dr. Tariq from Al-Amal Hospital, looking at the economical burden of dementia. And in this paper, we show that there is a variation in terms of prevalence. So obviously, countries where it have a higher population of the elderly are more likely to have higher cases. So places like Lebanon, Tunisia, and Algeria will have more prevalence of Alzheimer's than the Gulf region. So according to the figure there, maybe the Emirates is one of the least, and Qatar as well. Again, the regional risk factors, so things like lifestyle and consanguinity. So we have, within my clinic, I tend to see a family where both husbands will develop Alzheimer's because they are interrelated. Because people tend to marry within the family, which means that the son and daughter have to go through the double burden of looking after the person, and sometimes it's challenging because they'll have to split them. They cannot be in the same house, and when one person dies, the journey continues with the other person. So consanguinity is another issue, especially where the familiar type of Alzheimer's, things like regional risk factors. So we know that obesity is an issue. Previous speaker mentioned that. Obesity, unhealthy lifestyle, people unlikely to participate in sport, and easy access to fast food and talabat and all of those things means that people are more at risk of developing risk factor for developing Alzheimer's. Things like social isolation, which became more prominent during COVID and post-COVID. And sometimes we can see this digital isolation. So sometimes we have families where the elderly person will be sitting with the family, but the rest of the family are on their phones. So it's kind of, there isn't much of contact with the family. So again, this increases the risk of social isolation and the person becoming slowly developing less brain activities, and also limited access to healthcare. So when it comes to recent challenges, we're still facing issue with stigma, shortage of healthcare professionals who can detect, screen, and diagnose cases of Alzheimer's. We have problems with the lack of early detection. Most of the time we have people presenting with behavioral symptoms 3-4 years within the course of the condition, where it becomes very difficult to improve cognition, and also limited treatment option. And now we move to our topic for today. So artificial intelligence is a term used to describe the capacity given by humans to a machine, so it can memorize, learn, and from experience, and think and create, to speech, and judge and make decisions. So it's kind of very scary. I don't know if you watched any of the AI movies Hollywood was very keen in producing many years ago, where you have this machine which gradually takes over and kills all human and run the world. And I don't know, I think people are sadly skeptical about that. So the key issue here is that machines becomes more smart. It kind of outsmarts the person who creates it. And with time, it becomes more and more, learns more from whatever process is happening. And you could probably see that if you are into practicing and searching using the search engine. So the key issue there is that learning, so machine learning and Internet of Things are common things. So when it comes to healthcare in general, we've seen some of it probably developing already in other branches of medicine, like, for example, early detection of certain elements. So you have an AI-operated risk factor calculator. So you put somebody's profile, and then the machine will calculate what are the risks that this person will have a stroke, for example, or a cardiac angina. It also helps the clinician in making decisions using algorithm that is linked to guidelines. It can also help in dishing out treatment. Some pharmacies are already using AI-operated programs in terms of dishing out, dispensing medication, and some places it's more efficient and faster than the human being. Also things like expanding access to medical services, having associated care. We've seen during COVID lots of businesses flourished in terms of virtual clinics, and I was surprised to see even more complicated surgical specialty like orthopedic. In the UK, it was one of the specialties that was taken up in terms of doing virtual clinics. So it became more of a chance for the AI to expand and remote diagnosis and assessment to become popular. Sometimes AI can help us get more superior experiences with diabetes. I'm sure if you have a family member with diabetes, for example, they'll have those little kind of chip that would send information straight to the physician by using AI. And also more and more we are seeing AI used in end-of-life care. So again, AI stepping into helping professionals. When it comes to dementia, we could see that AI can help us through the process. So we were talking about the patient journey, starting from using computerized programs that can help detect and screen early cases. AI can also help us in movement detection. So we know that the person is up and learning. If a person is living on his own, so he's waking up, he's making breakfast, he's going to the toilet, he's coming back to the toilet. So, for example, in Western countries where people tend to live on their own, remote monitoring can help a person to stay independent while avoiding risk of having any complication. Also, this is useful in terms of tracking people who have risk of wandering. AI can also help in speech and language testing and also interpreting brain scans. We're seeing more and more radiologists being replaced, gradually replaced, because there are some studies showing that AI can now read MRI scans as good, if not better, than a trained radiologist, and also in setting up a smart environment. And now I'll go through a few examples of available screening tools that are available mainly in the West. The three I'm going to talk about are FDI, not necessarily approved, but have been screened by FDI. So there is a future for them to be incorporated into clinical care. The first one is known as Cognigram. So it's basically an iPad or a smartphone-based screening tool where the person is shown a set of cards, and by clicking the cards, it can help in assessing this person's attention, psychomotor functioning, visual attention, visual learning, and working memory. So this is done either remotely or sometime during the clinical assessment. So the idea is to get more accurate assessment for the person at early stages. The second one is known as CANTAB, which is short for Cambridge Neuropsychological Test in Automated Battery. Again, it's an iPad-based. It looks at motor screening, the ability to shift tasks. So the person is shown different instruction, and it can tell you if the person is able to shift between two different tasks. It calculates thinking time, decision-making, the ability to assess short-term memory as well. The third one is a program that's already available in the Gulf. I hear that people in Dubai are using it quite frequently. I'm not sure about here. It's called Cognitivity, and it works similar to the previous one. So it's basically an iPad-based program where a person is shown different animal pictures, and he has to click whether it's an animal or not an animal. So it's very fascinating. It works on iPad. The idea is that at the end of the test, the program generates a score, and it compares that score with a group of previous tests. So the more experienced this machine becomes, the more sensitive it becomes in clearing or assessing the condition. I have a video here, and I don't know if we can, just a quick demonstration of how this works. So basically, at the beginning, you give an instruction to the person, you hand them so they click right if it's a bird. If you don't see an animal, tap on the left. So this is an instruction stage. So it's both of using both hands. It shows how you should hold the iPad. Right, so you can see it didn't take 5 minutes, and the whole idea here is that it tests the ability of the person to coordinate, to shift tasks so they don't press on the same side of the screen all the time, their ability also to recognize what an animal looks like. And I tried it myself. I scored around 90 something, so I'm in a good position. So the idea is that the score you get is now out of 100. And again, this is a screening tool. It's not diagnostic, so people who score a lower score then can be offered a clinical assessment. Right. And there are a few published evidence-based studies suggesting its role and its acceptability for people in the medical field. These are some, those of you interested, they can look it up in YouTube. These are links showing how other tests work. Again, other uses are, you can use AI in voice assistant, reminding patient to take their medication on time. So again, this is very useful if a person has problem forgetting to take their medication. We can have wearable devices. This is a project we had about tracking devices for people who have memory problem. They leave the house, they find it difficult to come back. In our environment, we have catastrophes because people go out in a hot weather, they get found dehydrated, sometimes they die out of a heat stroke. So having such wearable tracking GPS devices is useful. We can also use virtual reality for cognitive stimulation for people who are in the middle stage, and also care management and support. Also here, AI is used in improving communication. So this lady has difficulty comprehending writing, so she will start writing in an iPad, then the AI will make it more readable, and so she can communicate with her family member if she can't use the spoken information. Also, AI can benefit in terms of improving early diagnosis, personalized care plan, storing data, monitoring the patients, and enhancing care support for caregivers. We've talked about ethical consideration. If we are all familiar about the 4 ethical principles that we use in medical ethics. So beneficence, we need to know that AI is going to benefit the people who are using it. Non-maleficence, so it's not going to cause harm. Autonomy, so the autonomy of the person, at what stage does the person have capacity to refuse wearing a tracking device, for example. Data security, where is this data going to go to be stored? An example, each country, they have their own cyber security system, so whatever information that is stored from those patients need to be stored in a very secure cloud. And also transparency and accountability, who is going to act on this data, who is going to be more responsible about them. future uses. So we are having more integration into daily clinical care. You could see that an AI is brushing an old woman's hair there. And this is a robotic child. So it's kind of very soothing for people in the middle and end stage of Alzheimer's when they have difficulty communicating. So they used what they call doll therapy as an example of helping persons to have some quality of life. So in conclusion, the number of people with Alzheimer's is projected to increase throughout the world. The situation is not different in the Middle East, and AI is showing good potential in terms of improving detection, helping person to live independently at the early stages, improving quality of the diagnosis, using more sophisticated and accurate screening tools, and also we need to be more open-minded in embracing those technology, having in mind that understanding the technical and the ethical consideration. These are my differences, and thank you very much.
Thank you, Dr. Hamad, for your valuable lecture. And now for the next lecture, it will be about the mental health training in the Arabic countries. It will be by Dr. Mahdi Said Abu Madini. Welcome, Dr. Mahdi. Dr. Mahdi is a professor of psychiatry, Department of Psychiatry, College of Medicine in the Imam Abdul Rahman bin Faisal University, Dammam, Saudi Arabia. He is the president of Saudi Psychiatric Association and the president as well of the Arab Board of Psychiatry. He is the former chairman, Department of Psychiatry in Dammam, Saudi Arabia, and King Fahd Hospital of the University Al Khubar, Saudi Arabia. He is a consultant psychiatrist in the King Fahd Hospital of the University Al Khubar, Saudi Arabia, and he is a vice dean of Quality and Development, College of Medicine, Imam Abdul Rahman bin Faisal University in Dammam, and he is author and or a co-author of more than 40 publications in referred scientific journals. He is a distinguished international member of American Psychiatric Association, and Dr. Mahdi, he is a member of several national, regional, and international scientific and professional societies and organizations. Please welcome Dr. Mahdi.
Thank you very much. Thank you, Mr. Chairman. And thanks to all audience who stayed until late this time. Firstly, I would like to thank the organizer for inviting me to talk about the Arab mental health training. And in fact, it's really still, I say, growing up, and we hope that we can have one day a standard for all the Arab countries. Disclosure, I don't have any support for this except that I'm the president of Saudi of the Arab Board, so no conflict of interest. We have to go and identify availability programs, then what are the need for mental health training, example of international trainings, then we have to explain the differences between the certifications and programs. Then we have to describe Arab Board certification in psychiatry and demonstrate the application for the accreditation. To go to mental health track, you know, the mental health education in the medical school is different in different country. The training is different, and the accreditation as well is different in different countries. In the medical school, they range from 3 to 12 credit hour, and the clinical training can be from 2 weeks to 12 weeks. In some country, they have 18 weeks of training. In Sudan, in Iraq, it goes up to 30 weeks. While in postgraduate training for psychiatry, there are two different types of postgraduate. One is the academic, which is the Master of Science, MPhil, PhD, master degree, and so on in the field. And that's the academic certification, which really most of the country you can be appointed as a faculty in medical college, but a lot of countries, they don't appoint you as a consultant with that qualification because you need more clinical training. And the postgraduate clinical training, it ranges from 3 to 8 years. The minimum 3 years is really only, maybe will give you core training like in UK where you have 3 years of core training. After you do the foundation year, we will see it in next slides. But to be appointed as a consultant, you have to do the higher training, another 3 years for the specialty to become a consultant. In some Arab countries, yes, they do have a program of 3 years where they can really get them appointment in their country only because they need mental health worker. Example of certification, as I said, there are postgraduate diploma, there are postgraduate certificate. Of course, this is the first. Then it will come postgraduate certificate in, say, psychotherapy, in child psychiatry, in whatsoever. So I'm not writing the whole, only giving example. You have a Master of Science, you have the MPhil, you have the MD, and you have psychiatric PhD. And this top usually is the academic degree where you can be appointed in education and teaching. While the clinical one, which bring you to more in the practice, you need to do really one of the board, which is like American board, Saudi board, Arab board, and so on. You have the membership, that, like the Royal College membership in Canada and UK and Australia and Ireland, New Zealand, and so on. And you have fellowship certification in most of the subspecialty. And some of the general training, they call it fellowship. In like example, in Saudi Arabia, there are fellowship of psychiatry general in universities. We will go over just examples from UK, from Ireland, New Zealand, Canada, and USA. And in USA, you know, it's a huge country, so you'll just see what they do in 3 samples: Johns Hopkins, Cincinnati, and Wake Forest School of Medicine. And why I'm choosing this? Because this is the most country which the people working in the Arab world, they are certified from these countries. So most of our colleague and senior who's been given scholarship to this country, like Prof. Hamid Sinawi here with us, he was in the UK, back in Oman. So they are getting the certification from this country. This is why I'm just touching on them to see the training and the difference between them and how we see it in Arab world later. Right, first in UK. UK, if we have any one of the senior who was in UK one time, it was only 4 years, and then you get the membership and you can be appointed as a consultant. Now it's changing. Firstly, you have to do a 2-year foundation year after graduation from this medical school. Then you have to do 3 years, what they call it, core psychiatric training. And after the 3 years, you have to sit for the exam, MRC Psych, and you will get that certificate, but you will never be appointed as a consultant. You can work as a specialist anywhere in the UK and other country and in the same territory of United Kingdom. But to be appointed as a consultant, you must have completed the higher specialty training, another 3 years, and then sit for another exam, which is the CCT, or Completion Certificate of Training. Having said that, it's a minimum of 36 months post-foundation, which means 2 years plus 3, 5 years. You will have MCQ written paper and clinical assessment of skills and competencies. And then you sit for the exam, and you have to get another 3 years for high specialty or higher specialty training in any one of these subspecialty, including general psychiatry. Which means people, they think that if they have MRC Psych exam nowadays, that they can work even as a general psychiatrist. Yes, but you will never be a consultant. Some examples of the training in higher specialties: child and adolescents, forensic, general adult, old age, psychotherapy, or psychiatry of liaison, psychiatry and learning disabilities. Right, so this is the way of the track, which is 2 years foundation after you get the medical school. One might say, why 4 year can be medical school? No, it's this is those who get the 4 year of science college, and then they go to medical college. So it's total of 8 years actually. But those who go for straight ahead to medical school, 6 years, then you have the 2 years. The 2 years here, you will see the difference between UK and the Arab country. Why 2 years? Firstly, 1 year is the internship, which everybody medical students is taking. But the difference is in some of the Arab countries, or most of the Arab countries, not some, almost all, the internship is considered pre-certification, which means that it's in the undergraduate. You finish the undergraduate, you do internship, then they will give you the certification. While in UK, Canada, no, you graduate from medical school, then you do the internship. After the internship, you do another 1 year, clinical year, and mostly they choose it toward the specialty. So they do it in primary care, in neurology, in medicine, and so on. Then you will do the 3, then you get the matching. Why matching? This is another problem which we have to look into it in the Arab countries. Because the slot of having trainees must be in a place accredited, and must be in a place where you have only a maximum number of how many candidates you can train in that accredited places. So once you been selected to go into the core training by the Royal College, which the Royal College is the accrediting body here, and GMC is registration to practice. So you go for 3 years, CT1, CT2, CT3, which is the core training. Then you sit for the exam, and this is only a certificate that you can go for the higher training in the specialty. Then again, you will be here, you have to go for another matching of the subspecialty, where they can give you the training post. Again, why matching? Because you need to have full-time equivalent, FTE. That mean you are not only there for service. You have time for training, for attending didactic lectures, seminar, journal clubs, and so on. While the other people who are doing service, they are not having free time to pursue their education. You go for 3 years, and then you sit for another exam, and that will make you ready to apply for a job as a consultant psychiatrist in the subspecialty that you took the higher 3 years. It's the same roadmap, and as you can see, the difference here, you will see it when we come to accepting young psychiatrists who will want to go and do training abroad. Then there must be a selection here so that you are free for the training only. Do CT 1, 2, 3, and then sit for the exam. Then you go for the specialty training 4, 5, 6, and then you sit for another exam, and you get the certification to be ready as a consultant. Right. In here, the difference is between UK graduate. This is the path, no problem with it, because it's clear for them as they are accredited by the Royal College as a medical school in UK. But in the other slide, if you see there, it is international medical graduates. And what is the difference? As I said, the internship, they have to accept your internship in your country, and you have to do other 1 year, and there are different slots or different type. Either they have to accept all the training you do in your country, or no, you have to repeat it in UK. It depends on which track you will do. Either you will go full, like the UK student, where you do complete 2-year foundation, then 3 years, then 3 years, or you go for CSR, which is a combined one, which means that you will have to do a repetition of your overseas training plus the one you completed from T1 to S higher training 6. Right. This is the CSR, which is if you don't complete the 3 years UK core psychiatric training program, but you do complete the 3-year higher specialty training, then you are on the certificate eligibility for specialty specialist registration combined program. This route is for international medical graduates who have already completed 3 years of experience or training in psychiatry. But remember that you have to provide certificate of proficiency in language, and you have to register as medical practitioners in UK, GMC registration. This is the track of the CSR, which is that you have to do the combination. And by the way, this is available in their website. So, but I am giving the example when we go to the next slide. This is the Article 14, which wavering of if you are already working as a consultant in your country by your local training or whatever, then how much they will give you to waive that experience. And this is the best for those who have completed training and have been practicing as a consultant for at least a few years. Or those who have completed residency and fellowship overseas and do not wish to repeat their training. You know, even in UK and the United States, they don't accept graduate of American Board of Neurology and Psychiatry to practice in UK. But they can accredit his training, and then they will give him a way to go into the higher specialty training. Right, this is the Irish. The Irish is the same. The Royal College of Psychiatry is the only body in Ireland approved trained doctor to become a psychiatrist. And to become a specialist doctor in psychiatry it takes at least 7 years, so it's not far from the UK, it's the same. But if you add to it the internship, that means it's the same 8 years. Training is divided into basic specialty training, which is in UK they call it core training, and followed by higher specialist training, which is ST 456 in UK. And this is the map of the route map of their training. Of course, you have to have exam here, like the membership of Royal College of UK, which is certificate of completion of basic specialty training, they call it. And you have to have another exam here, like CCT in UK, which is certificate of completion of higher specialty training. So to complete as ready to be a consultant, you have to have 8 years in UK, 7 years in Ireland. In New Zealand is almost the same. They have from stage 1, stage 2, stage 3, and you have to always have recertification, what they call it, or continuing professional development, lifelong learning, because this morning I met one of our colleague who already retired, but she's still practicing, and she said I have to go every year to UK to recertify my practice. Then training is 5 years in New Zealand, Australia. Sorry. It has to be accredited the training post, which means full-time equivalent, extensive clinical supervision, and the assessment from structured workplace-based assessment, as well as formal written and clinical exam. This is roadmap, like what they do there. So it's just only if you want to know the detail, if you are going there, you have to read it so you know how much you will spend on reading and attending didactic classes, and the minimum requirement that you need, what they call it, EBAs or professional assessment, entrustable professional assessment, they call it. Right, in Canada, coming to Canada, this is near to the same practice of other country, except it's lesser, it's 5 years. It used to be 4 years, but the first year or postgraduate year 1, they call it postgraduate year 1. Why it's not coming? This is not the same slide there. Okay. It's not coming here. Anyway, so it's postgraduate year 1, postgraduate year 2, 3, 4, 5. 2, 3, 4, 5 is completely almost psychiatry, with its specialty as you go and depth as you go up. While first year, it's like the internship. But in Canada, the internship, after they certify and give you the medical school, and then you will be geared toward your specialty. So if you want to do psychiatry, then there is a roadmap for psychiatry. If you want to do surgery, roadmap for surgery. For psychiatry, you have to do medicine, neurology, family medicine, and any one of the other for subspecialty. This roadmap, they start to change it from 2015, but in the recent years, they apply what they call CBD, or competency by design. which is there are certain entrustable professional assessment where you have to achieve it to go to the next step. And again, it's 5 years, and you have to go through these steps. I am here not to discuss the CAN-MED, but to give you the example so that we can see where are we in our area. Right, in USA, I just choose 3 universities, and they have the ABB, which is the American Board of Neurology and Psychiatry. They have postgraduate year 1, then year 2, year 3, and year 4. And in each year, you have to pass, you have to do these blocks. And in these blocks, there are selective and there are elective. So you must do one, and the other, it's up to your choice and up to availability in the same hospital where you are doing. There are extensive supervision as well as examinations. This is Cincinnati, which is almost, you can see, the same. Postgraduate year 1, year 2, year 3, year 4. And it's a 4-year curriculum, including over 340 lectures, designed to cover all the content area of the American Board of Psychiatry and Neurology, certification exam in psychiatry to ensure competency in psychopharmacology and psychotherapy. That means you have to attend the didactic activities, including seminars, tutorial, journal clubs, and so on. While what we have seen in some of the Arab countries, no, it's just they are doing service and reading and sitting the exam. Right, this is Wake Forest, the same. It's just I'm telling, giving it as example that all around all America, it only the differences between the elective and selective rotation where it is available and where you have to complete it from. This is the didactic lectures and activity, which is for each year, postgraduate year 2, for example, here, and there is cycle 1 and there is cycle 2, which means that it's you have to do that, then next you go for the higher in depth. Now, coming to our main, the Arab country. The League of the Arab States in 2010 consists of 22 countries. And this is why when I say the need to, because it's a huge area, which is 13 million square meter, and as well as a huge population, but scattered in this huge area. It's almost 456.5 million population, which means that we need really to have a training to serve those people in this huge area. 17 states which already they are registered in the Arab board, but only 13 which they are already having Arab board accreditation, and they are doing the program. When reviewing the literature, Professor Tariq Ukasha published a paper in 2020 where he just collected information from the Arab countries, and they published the postgraduate and undergraduate availability, which is almost the same as I said. that it range in medical education from 3 credit hour to 12, and training from average of 3 weeks to 12 weeks. But there are exceptions, as I said, in Sudan and Iraq. This is the undergraduate. Well, this is the postgraduate, and here you will see those who do postgraduate in Egypt, Sudan, Saudi Arabia, Iraq, Jordan, Lebanon, Oman, Qatar, United Arab Emirates, Palestine, and Algeria. And the numbers is the years of training. So in Egypt, 3 to 4 years, Sudan 4. 3 years is the high diploma, master, and the academic one. But all of them, they are doing 4 year in clinical training. This is undergraduate, right. This is the Arab countries the list, which is the red one is the now those who are already having a members represented in the Arab Board of Psychiatry Specialty. Tunisia, Algeria, and Morocco, only this year they joined us. The rest, they are before registered in the Arab Board. However, and here I'm just giving the population and the area from the World Bank data, so to see the need. And now you can see here what is in yellow is the clinical degree, while the one in green is availability of academic degree, which is a master, MPhil, and PhD. You can see the Arab Board, those countries who already registered, as I said. So, for example, here in Emirates, there are candidates from United Arab Emirates. Only few countries have a national board, which means, say, for example, there is Saudi board, there is Egyptian board, and so on. Although, for example, Syria, they are not in the Arab board now, but they have their national board, as well as Kuwait. Anyone here from Kuwait? I think KIMS, which is still, it's in its few years only they start to graduate people, but they are not joining the Arab board. The fellowship, i.e., for example, university fellowship, which is clinical degree, different from PhD, or subspecialty fellowship. And in Egypt, there are 5 or 6 subspecialty. In Saudi Arabia, there is subspecialty in child and adolescence and addiction. And in Qatar, it's written in the paper that they have subspecialty in old age, but I haven't heard it before that, but I've seen it in the paper. While the academic, usually it is from the universities, and you can see it's only in Egypt, Iraq, and Kingdom Saudi Arabia, where they can give master degree or PhD. Diploma, it's old fashioned, not anymore really, but still we can see it in Qatar, I mean academic diploma. This is just brief about the Arab Council, which is started in 1978, first meeting in 79, but psychiatry was one of the first, not first, it's only few in the beginning, but later on, which means you can see from 79, 89 started the psychiatry. The first people started in 92 and graduated in 96. And if you see how many people registered, total registry 2,122. and this year 98. While since its start, 843 graduated, and this year 59 graduated. The now registered student in the Arab board, currently at this moment, from the registry, 572 candidates in all Arab countries. These are the accredited hospital, but I have to stop here to say we have a problem of accreditation, because accreditation depends on the country. For example, they agreed on any hospital accredited by the local registry must be accredited or will be accredited in the Arab board. But last year, the Arab ministers of health, they said we have to revise it, which means each hospital have to be re-accredited. So they have to go and visit them and see actually do they do the program as it is supposed to be or not. So there is a huge change in the Arab Health Council. A child, they have only 2 or 3 subspecialty, which we started only a few years back. A child psychiatry already accredited Bahrain, Egypt, Lebanon, and we have candidates in them, registered already 12. Old age, I found that there are a registry, but old age psychiatry, we approved the program. We did not yet visit any country to accredit hospitals. Dr. Hamad Sannao is here. He's old age psychiatrist, my colleague who previously did the presentation, and he is one of those people who bought the program. But to my knowledge, they've never visited any hospital to accredit it, so I don't know why they are registered. And this is why I said, the Arab minister said, you have to stop accreditation and revisit it to see. So what I guess is those who registered in Saudi Arabia and Egypt, is they registered in their local and automatically they apply for the Arab board. This will not happen. Those candidates will not sit for exam until the people from old age go and visit and accepted the training in the place. The same with the addiction. Time? What's this? Okay. Core rotation, providing a strong and comprehensive ground in principles, general psychiatry and basic sciences related to behavioral health. First 2 years, general adult psychiatry, with specific focus on medicine and clinical neurology. This is we are talking now in the Arab board. The 3rd and 4th year, continuing emphasis in adult psychiatry, and then a specialized area like child adolescent psychiatry, forensic psychiatry, substance abuse disorder, geriatric psychiatry, consultation liaison, psychiatry, and any other available specialty, like for example psychotherapy. We still have a problem with it. And here we have really to revisit it. If you see all these subspecialties, only to give him a basic knowledge about this subspecialty. But it's not like UK where if you finish that you will go and practice child psychiatry. No, you have to do further training. Didactic program like any other didactic program, but it's been put in the program that you have to attend seminars, tutorial, journal clubs, clinical case conferences. But do they actually do it? If you go to hospital here, and do they have this program clearly? You can retrieve it and see it. The accreditor can come and see it, and we have the portfolio from trainer and the student. This is why we have to revisit so that we can standardize it. Assessment, it's almost like any other assessment, because when the people put the program, Dr. Hamad also, he's in a training committee in the previous council. So they saw the same programs around the world, and they took whatever available and could be implemented in our area. End of rotation assessment, examination part 1 and part 2 of the Arab board at the 2nd and 4th year, periodic logbook, and we have problem either in this, because when we ask about logbooks, no hospital gave us a logbook of trainees, and that's another problem. Assessment by the trainees concerning training program and evaluation will be discussed in the trainees training committee and training director, verbal feedback, and so on. Eligibility, completion of 1 year of training. Although we said the exam will be at the end of the 2nd year, but if you complete the 1st year, you can sit the first part, the written exam. A recommendation letter from coordinator and program that you completed the needed rotation. Format of the exams made from 3 parts, part 1 written, part 2 paper clinical, and oral or FIFA. Part 1 written, we have a blueprint for it. I mean, i.e. what representation of topics in each one of it. Part 1 written, paper 2, the previous one is, it's 2 paper. Paper 1 is 200 MCQ, single choice with answer, 2 and 3, 2.5 hours. And then part 2 MCQ, single best, tested in psychotherapy and clinical psychiatry. This is more descriptive psychopathology, psychiatric assessment, major clinical syndromes, and others. In part 2, again, it's paper 1 is 200, and it's more of a subspecialty here, where you have general adult psychiatry, old age, child, substance use, and so on. While in paper 2 is a problem solving, so it's only 60 MCQ in problem solving. In final OSCE, the exam is in English language. The passing score is in all exam is 60. If you did not reach 60%, you will not be given the pass rate. The final clinical is OSCE 1 and 2, 40-40, and oral FIFA, which is 20%. That's it. I will not go into the detail of the format because it's clear to everyone. Now, conclusion. We need a clear and well-structured foundation period because, as I said, foundation available in all other countries except in the Arab board. But we have to stop here. Are they going to give it? I mean, the scholars, the ministers, are they going to give more years to the candidate because they need them to finish in 4 years and come back? So if you give them another 2 years, it will be too much to send one for 6 years to come back as a psychiatrist. Do we need increase in the training period? I mean, 3 years and 3 years, and we are doing 4 years plus the 2. We have to think of it, and we have to discuss it in higher authority and to be accepted by ministers. We need to do a trajectory or roadmap. We need to really emphasize in the in-training assessment methods. We have to have milestones or EPAs or what they call entrustable professional assessment, and that's which is applied in most of the first world country. Portfolio, trainees portfolio, we have to emphasize on that because we don't have it. Only the letter from the hospitals that he finished the 4-year training, but what did he do there we need to have it. And we have to have policy and procedures for trainees and trainers. Proposed changes, foundation period, 5 to 6 years instead of 4 years only. Internal medicine and neurology, they must do. Introducing OSCE in part 1, clinical review paper in part 2. This has to be discussed for approval. Thank you very much. This is my references. Thanks a lot. It is one of the elective subspecialties because research. We will consider it as one of the elective, but not a must.
What are they using with the FDA? Where are they distributing the subjects? Why is it, مثلا, 7 years almost post medical school? Where is the need to stay so long in each specialty? مثلا, we're talking about psychiatry. It's been 5 years altogether. يعني نحن بلبنان 5 سنين.
The science is becoming more and more, and knowledge is expanding. So we need it, and the subspecialty, everyone will say no. You cannot practice child psychiatry because you need to do more in child psychiatry. This is why if you are doing a higher one, so you do the 3 years, yeah. But if you do only the 3 years, are you going to practice as a consultant? I don't know. Yeah, Dr. Ahmed, you want to say something?
Thank you
for
your
format. Our program
Thank
is
you.
5 years.
And
subspecialty is included with that kind of residence program, like what you guys explained by Dr. Mahdi. At the end of the day, you graduate a general psychiatrist, but they need to have clinical experience and exposure in subspecialty, old age psychiatry, psychotherapy. And our program is mandatory to have a research project. So you can't graduate unless you submit a full research project with thesis. Some of the residents will be publishing, but that is included as we call the research block. So within the 5 years program, they get 2 months free to do a research project from beginning to the end.
A lot of medical because you don't have people to train at those times. Exactly. When you were trained, you don't have that train.
Any more questions?
Assalamu alaikum wa rahmatullah. Thank you for the chairman and for both the speaker for both interested topics. My question for artificial intelligence related to it. Can we use that because I am a clinical pharmacist and I'm working with addiction now. So for relapse, can we, there is any chance, hope to use artificial intelligence to predict the relapse for a patient?
I don't know because that's not my field of expertise. My focus was mainly looking into dementia because that's where the area I am working with. But I think there are lots of ethical considerations, and people are very keen about setting up clinical vigilance and guidelines about to what degree can you rely on such things, because obviously things like might have impact on criminal outcome out of, in most countries, certain drugs are considered as a crime to use or deal with. So people are still a little bit reluctant to use that fully on its own. But you never know, science is developing very quickly.
I can say yes, it can be, but it needs development. If you listen to our previous sessions from the doctor who applied the psychotherapy for even he's deaf. So if you can predict that the patient is having signs and symptoms coming back, then you will say, oh, either he's not taking his medication or you need to increase the dose. So it's really going fast, artificial intelligence now, and if you read in it, you will see amazing things.
My questions to Dr. Mahdi. I mean, how do you look for the future of the Arab world in the time each country tried to initiate and, to establish their psychiatric board? I mean, for example, like Saudi board, they have since long time, and now we have the Emirati board, Omani board. So it will be more integrated, or it will be a competitive for that one, to compensate it.
Firstly, I hope that every country have its own board. Because if they want to apply a board, their national board, and to really think that they need to purify it, then they will look into the Arab board how to come together and make it standardized. And those who did their local board, for example, so because we need, and it's not started for psychiatry, we need board for other specialty. This is coming both together. But as an Arab board, I think in 2 months ago, we were in Jordan, in Dead Sea. They made a celebration of 45 years of Arab board specialties. After 45 years, where are we now? And then I think now they are the Council of Minister of Health. They want really to push hard to make it more standardized and accepted by all other countries. Because still you have the Arab board certification, but some country will appoint you, some country will not appoint you unless you work for 5 years and so on. Why? Because it is not standardized, and this is why they said we have to cancel all the previous accreditation and revisit it.
شكرا دكاترة، ومشكورين على جهدكم في تعليم الأجيال هذه كلها، وهذا كله مقتطع من وقتكم طبعا، جزاكم الله خير وشكر مجهود. الفترة الأخيرة بس just honoring the guest.